Yeah. So we're ready to get moving? We are 3 minutes after 1:10. So let me just once again echo everybody's comments and sentiments that, you know, we're proud to have you here at Bascom Palmer. Personally, it's great to get people like Doug Anderson and Paul Palmberg and David Greenfield and Steve Getty and Rich Parrish here. And, you know, to hear some of the discussions, it's really part of the reason why I came and wanted to be here, to kind of hear how they think and approach things, and, you know, hear some historical perspective is to me is inspiring. And so it's great that we're able to be together, and thank you guys for coming, taking time out of your busy lives. This is, I think, the first time we've had every school or college of optometry here at our educators meeting. So it is great. And hopefully you had a chance to get a little tour. I thank my residents or our residents for kind of touring people around. It would have been unfortunate had you been here and not had the chance to really see what Bascom Palmer is. And as John said, it really is the people that have really makes this place very special. So we're going to proceed. Let me introduce David Greenfield. So David has the Douglas R. Anderson Distinguished Chair in Ophthalmology. He's Vice Chair of Academic Affairs for the Department of Ophthalmology. He's co-director of the Glaucoma Service and director of the Glaucoma Fellowship Program. David did his MD degree at New York State University Medical School, residency training at Tufts New England Eye Center, and did his fellowship not only in glaucoma, but in neuro-ophthalmology as well here at Bascom Palmer. You're used to seeing fellows kind of come and go. And David just was one of those guys. If he was here for a long time, you would always see him. He had a lot more hair back then when I remember him. This was the 90s. And so when David left, he went up to New York. And when he was in New York, he met a friend of ours, Murray Fingerette. And I remember Murray talking about his relationship and friendship with David. And it's no wonder, right? Both of them have this strong and keen interest in glaucoma. So when David came back, so David is largely at the Palm Beach Gardens location, which is about half the size of this. It is a beautiful, standalone, state-of-the-art, we call it, looked like a Taj Mahal in many ways. But so I don't get a chance to interact with David as much as some of the other glaucoma faculty, but obviously David's resume speaks for itself and what he's done in glaucoma. So with that, let me turn it over to David.
Greg. Thanks so much, Mark, and to our local hosts, John, and our not so local hosts, Murray and Mike. It's a real treat for me to be here to honor the legacy and lifetime achievements of a really a legend in the field of glaucoma, I think one of the reasons I chose to pursue additional training in neuro-ophthalmology was because of Doug's recommendations. And, the impact that he had on my career and my training can't really be emphasized enough, as well as multiple generations of glaucoma specialists that he trained. We often hear about the founding five. Dr. Anderson was number 6. So arriving in 1969, founding the glaucoma service, and his legacy of lifetime achievements and accomplishments really speaks to itself, including the people that he trained. One of which was Harry Quigley, who I have the honor of introducing at the 2016 AGS annual meeting when he was the honoree. And it was great. Just by disclosure, my only disclosure is I'm a consultant to Nexon. I'll be speaking about drugs and lasers. So there you have it. But when I introduced Harry, it was interesting to see that Harry was a fellow of Doug's in 1975. So that would have been about 6 years after you started your career here. And Harry was a lifer at Wilmer and migrated down to South Florida, really because of Doug and his interest in wanting to learn from the master. And I think I got this slide, this photograph from Harry, and I showed it first to Harry, and then I showed it to Doug, and I asked for each of their individual feedbacks, what it meant to them and what they could recall. And from Harry, Harry recalled, "I had the joy of learning clarity of thought and objectivity of science from Doug." And that's what brought him down here to pursue his fellowship training. And then Doug, I don't know if you recall, but I showed, the picture to you, and I said, who else was in the picture? You can see Harry on the top left, and obviously Doug next to him, sporting some very fashionable T-shirts. And I think Doug I was trying to jot down your exact quote, but if I had it right, I had Barry Davis was my lab tech, from whom Harry says he learned more than he actually did from me. So same picture, two totally different perspectives, but generations of glaucoma specialists are really indebted to you for the wisdom, for the leadership, and I think Harry really nailed it. Clarity of thought, we saw that in the lectures that you just gave, and objectivity in science. That really encapsulates it. Now, I mentioned the fashion for a reason, and that's because many of you know that, Dr. Anderson and his contributions in glaucoma, you might not actually be aware that he was an icon in the fashion world as well. And this says, "Is this what the well-dressed faculty member will be wearing this year?" I don't know where I got the photo from. Actually, we'd have to discuss that in the Q&A maybe. My photograph.
That was at the time that there was a dress code that was being implemented for the employees at Vascular Palmer, and this originally the caption was "This is in the dress code." The person publishing it in the weekly newsletter for the faculty and staff changed the caption.
I was going to ask where it was published. It wasn't in AJO, but could be, Rich. It could be. This is a snapshot from when I was a fellow, 1994. Obviously, you see Paul there, Don Boudin's flanking the other side, my co-fellows, Jim Robinson, Daryl Wudun. There's Jack Tribble, Sridhar Padarazu, and of course, Dr. Anderson in the middle. And nothing could be a greater honor for me than to be the holder currently of the Douglas R. Anderson Chair in Ophthalmology. I'm the second holder after you. Things I learned from Doug. And I just wanted to encapsulate a few on the slide here. So anybody who has seen patients with Doug quickly realizes that it's easy to take care of patients when you put the needs and the interests of the patient first and foremost, and you do the right thing. That's a mantra I think that everybody who's had the privilege of seeing patients with him will understand. From research, you saw from Harry's words, clarity of thought and objectivity of science. But I think something that I remember was you start out when you're trying to think about a study by defining the question. And if you don't have the question well defined, then the study will fault as a result. So you really start from the beginning and define the question. I remember giving a presentation, and I showed you the presentation, which I had spent quite a bit of time on. And at the end, I think you said to me, too long. What do you want to leave the audience with? And I think I started to say this, that, the other thing. He said, no. Top 3 things you want them to remember. No one's going to remember more than 3. They're probably only going to remember 2, and more likely, but if you're lucky, 1. So that stuck with me. And don't use a lot of slides. And many of us who heard your infamous talk at AGS with a single slide of the eye will realize that. Think outside the box. And we certainly saw examples of that in your first couple of lectures today. Be wary of messaging. This is an interesting one. We saw a rabbit a couple of times in the slides today. And I remember seeing a patient with normal tension glaucoma who was being treated with timolol. And I said, you know, would there be potentially a role for betaxolol in this patient if you think there may be some autonomic dysfunction or autoregulatory dysfunction? And I think we went on to talk a little bit about the vascular biology of the optic nerve circulation, things that can influence it, this, that, and the other thing. And in the middle, you said, look over there, a pink rabbit. And I turned my head. And when I don't know why I turned my head. I mean, we were in the middle of clinic, but I came back and I looked at you and you said to me, don't believe everything you hear. And walked away. So we did see a couple of rabbit photographs today. So I think we'll all understand a little bit more where that background is from. So I'm going to talk a little bit about drugs and lasers, and then Steve Getty will follow with me with surgery. And I think my charge was to discuss things in the last decade. So I'll be sharing things from 2010 to the present and what's new in medicine and laser. And I wanted to begin a little bit about a medical breakthrough, because, well, we don't have any in what I'm going to be discussing. But it's useful to think about a medical breakthrough from various perspectives. What is a medical breakthrough? Well, Merriam-Webster defines as a sudden advance in knowledge or technique, but I'll add to it that it should really have some substantial improvement in a patient's quality of life to really be a significant medical breakthrough. We've got quite a few in ophthalmology. If you think about it, Charlie Kellman and the advances in cataract surgery with phaco-IOL implantation, Carmen Puliafito, Jim Fujimoto, David Wong, all the co-inventors of OCT, really it changed the way we take care of patients in ophthalmology from the front of the eye to the back of the eye. Gene therapy for an otherwise untreated causes of vision loss with inherited retinal dystrophies. And probably the most important is Avastin, right? Really enormous ways in which they have improved patient vision, patient quality of life. These are substantial ophthalmology breakthroughs. Glaucoma breakthroughs. Now we'll get a little bit more granular. Some of which we've talked about, and automated perimetry initially with the gigantic octopus perimeter in 1974. And Mike Patella, what you and Anders and Bohl have done with the advancements in Humphrey perimetry is really in a substantial breakthrough for taking care of patients that is going to endure forever. Laser trabeculoplasty, Jim Wise and Witter. I still do occasionally argon trabeculoplasty, but obviously selective laser trabeculoplasty is an enormous breakthrough. The concept of target IOP, initially introduced by Chandler and Grant in the 60s, mostly the 70s, they had it pretty simplistic. If somebody is really bad glaucoma, they're going to need a lower target, probably somewhere in the mid-teens, I think they said. And Paul really made it much more granular and in a way that we really understand, and it's a major breakthrough. Drugs, latanoprost. I don't think we're ever going to get much better than that. The joint contributions of Laszlo Bito, Johann Sternschanz, Anders Bill, Carl Kamras, and many others is a game changer in the way that we can lower pressure with a single drop with no systemic side effects. Anti-fibrosis therapy in the early to mid 80s by Rich Parrish. I mean, game changer. Trabeculectomy would not have been a useful surgery without it. And pretty much all our patients now benefit, if not from 5FU, from trabeculectomy with mitomycin C, introduced initially by Chen. And tube shunts, we'll hear a lot more by Steve Getty. Getty, you should be on this list too. I got to add your name, but that'll be in the next generation of this talk here. But the contributions of Maltino, George Breirveld, Ahmed, Steve Getty really are breakthroughs. Nothing that I talk about today is going to be a breakthrough. But I will provide an update, and what I'm going to be discussing is outlined here. In terms of prostaglandin analogs, I'll talk a little bit about LBN, latanoprostene bunode, tafloprost, also known as Zioptin, and of course Zelpros. Those are BAK-free alternative PGAs. ROCK inhibitors, we heard Doug introduce them with a dual mechanism of action. There are two of them, notarsidil and the fixed combination, notarsidil and latanoprost. Ropress and Rocklatan is the marketed names. Sustained delivery, I'll talk only really about what's available. So I'll talk about bimatoprost sustained release, or Durista, and also talk a little bit about the impact of specific drugs on visual fields over time, which was something we explored in the low pressure glaucoma treatment study. Shifting to laser therapy, micropulse CPC, we know that there are a couple of different ways to deliver cyclophotocoagulation. You can do it through a transscleral continuous wave approach. You can do it endoscopically, or ECP. What was introduced in the last decade was micropulse cyclophotocoagulation. And then I'll talk about some potential innovations in the way SLT can be delivered directly without the use of a contact lens through a translimbal approach, so-called direct SLT, and then some trials like Light, Eagle, and ZAP. So let's begin with LBN. LBN is basically a latanoprost moiety with a nitric oxide arm to it. It's a FP receptor analog, like latanoprost. It has a dual mechanism of action for IOP lowering. That is to say, it works through enhancing uveoscleral outflow. And was pointed out earlier, it also does enhance conventional outflow through the trabecular meshwork. I'm showing you the phase 3 trial data on the right in comparison to timolol. And you can see that at the weeks 2, week 6, and month 3, at all time points, why LBN was about a point better than timolol. If you look at phase 2 data that was published in BJO, Bob Weinreb looked at data comparing latanoprost without the NO donating moiety to LBN in 400 or so, 413 patients. And it was found to be about a point better than latanoprost. So does that surprise anybody? Maybe, maybe not. Concentration's a little different. 0.024% is more than a 4-fold higher concentration of latanoprost. So whether or not it was due to that higher concentration or the NO moiety is really unclear. But suffice it to say, it is stronger medication that does produce some more hyperemia. But it's, as we see from phase 2 and phase 3 data, stronger than timolol, stronger than latanoprost in a large group of people by about 1 millimeter of mercury. BAK sensitivity, in my estimation, not a very prevalent problem. You hear a lot about it. You hear that some individuals need to have BAK-free medications to reduce the subjective senses of foreign body sensation, dry eye, discomfort in general. And I have found no substantial subjective improvement with BAK-free products in my practice than BAK-containing products. But there are 2 available for people that truly have a sensitivity to benzalkonium chloride, one of which is tafloprost, initially introduced by Merck, changed hands a couple of times, and I think now is marketed by a company called Thea, I'm not sure how to pronounce it. And of course, the emulsion version of 0.005 latanoprost, which is Zelpros, marketed by Sun Pharmaceuticals, does have preservative, potassium sorbate. It's not BAK, and that's why it's in a bottle that does not require refrigeration. It's not a single-use vial because it's preserved. It just does not have BAK. And there are some people that truly are allergic, have contact dermatitis to BAK. And for those individuals, I think there are these options as well as other topical agents. There's, of course, SLT and oral agents and surgery. But at least in my estimation, I have not found the BAK problem to be all that much. ROCK inhibitors. So 2 of them available that we mentioned earlier, and that's Ropressa, Notarsadil, 0.02%, and of course the fixed combination Rocklatan, marketed by Aerie, now Alcon, who just recently acquired the rights for marketing for both these medications. And I'm showing you the phase 3 data for Ropressa on top, and the phase 3 data, the Mercury trial for Rocklatan on the bottom. So on the top, you see that Notarsadil was more effective than Timolol, again, at week 2, week 6, month 3. I should say not inferior. That's probably a more accurate phrase. And that is their label. They're not inferior to Timolol. And their mean pressures at all time points were essentially the same. And if you look at the phase 3 data on the bottom for the fixed combination, you see that the fixed combination was superior in efficacy to each of the 2 individual components, that is to say, latanoprost and Ropressa individually. So that's not surprising. It is interesting and exciting anytime a new potential class of medication is introduced. And certainly this was a new class and they are first in class. And if patients can deal with the hyperemia, which is not insignificant in a large group of these patients, it does add to our existing armamentarium to further lower pressure with a once-a-day administration. Sustained delivery is really, really important. And compliance is our biggest hurdle. We all know that. And sustained delivery offers the best opportunity to deal with one of the greatest risk factors for blindness. And that was something, if you read Grant and Burke had a great publication, I think 1982, called "Why Do People Go Blind from Glaucoma?" And boiled it down to a couple of different reasons, one of which was, well, we probably don't take care of the people with really advanced disease early enough and aggressively enough. And another one was compliance. And, we actually have intent to treat in our practice. We write a prescription, intend to treat, hope the patient is compliant both with the medication and the follow-up. And very often that just is not the case. So sustained delivery offers the best opportunity to seriously combat glaucoma vision impairment. So I'm showing you in the slide on the left various different types of potential alternate deliveries other than just eye drops. The one that's obviously reached FDA approval that is now available is Durysta, marketed by Allergan, and that's the bimatoprost sustained release, 10 microgram concentration, pretty easy to administer with a 28 gauge needle at the slit lamp. And after 4 months, you can expect to see about a 30% reduction in intraocular pressure. And in the phase 3 study was not inferior to topical bimatoprost published in AJO. And then follow-up data, not inferior to Timolol, published in 2020 by Felipe Medeiros. One important consideration is look at the proportion of corneal endothelial density loss, or CED, and that's 10% of patients with 3 injections of Durysta had a 10% loss of 10% of the entire population of patients that received 3 injections had a 20% or more reduction in corneal endothelial density, which is substantial in a short period of time because there's a foreign body. And very often it's not just fixated in the angle, but it moves. And that's right now one of the most important reasons why Durista has a single use indication. Can't give it more than one time, which limits its clinical applicability for most patients. Glaucoma is a long disease, a single injection, not going to do it. Although I will say that in many patients, you might get much more than 4 months of IOP lowering. Other alternatives, again, by Allergan, there is a bimatoprost ring that can be placed inside the conjunctival sulcus. And remarkably, almost a 90% retention reported by Jamie Brandt in 2016, lowers intraocular pressure from baseline by about 20%. I'm not aware that this is ready for prime time yet. I have not seen phase 3 data, but again, published data, so I'm presenting it. And then, of course, one of the more interesting potential products for sustained delivery is the iDose travoprost attached to an eye stent. Phase 2 data published by press release about 3 years ago showed that you get about a 30% reduction in intraocular pressure, not inferior to timolol. Phase 3 data expected, top-line data, maybe the end of this year or Q1 of next year. So many of us look forward to seeing what the results of that will be like. Finally, I mentioned that that drugs do more than lower intraocular pressure. They actually have impact on visual function. And it's typically not something that you think about, not something that you that the FDA thinks about, because drugs, as you see, might be a 3-month study for phase 3, mostly compared to timolol, on their safety and efficacy with regard to the gold standard, which is timolol. But they have impacts on visual function. And this was a study led by Ted Krupin in normal tension glaucoma patients called the LOGIT study, where we randomized patients with bilateral low pressure glaucoma. And they received either treatment with timolol 0.5% twice daily in both eyes, or brimonidine 0.2% twice daily in both eyes. Why do we use those medications? Well, they both lower intraocular pressure about the same, and they are both twice a day. And the administration, therefore, was masked to the patient, and the administration was masked to the treating investigators. And as you can see on the bottom left, if you look at the Kaplan-Meier survival curves for visual field progression, you see a substantially higher rate of visual field progression in the eyes that were receiving brimonidine compared to the eyes that were receiving timolol. And on the right, I'm showing you the average IOP reduction in both groups, which was A, not different between them, and B, not that much compared to baseline. And they had a very low baseline pressure. We know drugs don't work as well when you're starting with a very low baseline intraocular pressure. So we looked at visual field progression lots of different ways. We looked at them using pointwise linear regression analysis, which is a software largely utilized in the UK called Progressor. Uses regression analysis to monitor the fields. And when you see a significant repeatable change, then it's progression. But we also looked at glaucoma change probability. We also looked at a different strategy called the 3-omitting method of visual field progression. We also looked at disc hemorrhages in a masked analysis. One night, Ted Krupin, myself, Jeff Liebman spent the wee hours in the morning looking at optic disc photographs. We didn't know who was receiving brimonidine. We didn't know who was receiving timolol. We just flashed the optic nerve photograph. And if all of us agreed there was a disc hemorrhage, we recorded it as a disc hemorrhage. And the difference in not just one, but recurrent disc hemorrhages between the eyes who were receiving brimonidine compared to timolol, well, the p-value was 0.06. pretty close to statistically significant. We just didn't have that many disc hemorrhages as a group in general. But why did this happen? We don't know. There hasn't been a follow-up study. Was it because brimonidine was potentially neuroprotective? Was it because timolol did something disadvantageous to the visual field? We don't know that either. I will tell you that Hayray published in the mid-'80s that in his experience, eyes receiving beta blockers tended to progress more frequently than the eyes that were not receiving beta blockers. So be that as it may. We're going to move on to laser treatment. And I mentioned micropulse delivery for transscleral cyclophotocoagulation, which is utilizes a distinct kind of probe, not the G probe that we're used to when we do transscleral cyclophotocoagulation with a continuous wave laser. What makes this kind of delivery interesting is that it's pulsed in very, very short intervals. So it was initially believed to be less destructive to the ciliary epithelial cells. And the problem when you do cyclophotocoagulation is that when you destroy the ciliary epithelial cells, you destroy the blood aqueous barrier. These eyes leak protein and inflammation ensues. They get iritis, they get cystoid edema, they lose vision. So the potential was that if you do these sweeps the way they're intended to be done, which is 90-second sweeps with the micropulse delivery at the superior limbus, and then 90-second sweeps at the inferior limbus, that you would achieve substantial IOP lowering without all the cytotoxic injury to the ciliary body epithelium. Does it work? Well, I'm just showing you one single publication. There really aren't that many, and there were 73 eyes with a year of follow-up, and apparently about 3/4 had about a 20% reduction. This was published in Ophthalmology Glaucoma, and if you ever want to read a scathing editorial, why I'm showing it to you on the bottom, and Harry Quigley points out all the flaws of the study and why you have to be a little bit more skeptical and critical about new technology before introducing it in your clinical practice. I agree with all the comments that were made in the editorial. Direct SLT, why this is different because does not necessarily require any kind of coupling agent or contact lens, and the delivery system is translimbal. And this is a technology that was developed by Michael Belkin in Israel. The company is Eagle. And it uses a fixation device that allows you to track eye movement when you deliver the SLT laser energy, which is basically like standard SLT. It's 100 spots, 360 degrees. Each spot is 400 microns. It's a frequency doubled YAG technology, just like regular SLT. So it's 530 nanometers. It takes 2 seconds, and I mentioned there's tracking that allows the, during the 2-second delivery, allows the delivery to stay right at the limbus where it should be applied. IOP in this very small study of 15 eyes that was published last year in TSVT was reduced from 26 to 19 millimeters of mercury, and patients were on 1 fewer medications. There is some concern about the development of PAS, or peripheral anterior synechiae, since you're just treating the laser directly in the angle. Gonioscopy was not performed before and after. This is not part of the protocol, so remains to be seen what the long-term IOP effects of this delivery is, but 15 eyes, there you have it. A couple of other studies that I'll mention. SLT, we're all familiar with the LIGHT trial, which was a really, really important study that randomized patients to receive either primary selective laser trabeculoplasty or initial medication. And a lot like the GLT study that was done in this country years beforehand, and very similar follow-up, very similar findings as well. 718 patients were randomized with 3 years of follow-up. And as you see here, 3/4 of them were able to achieve a target pressure without medications, 3/4 with a single SLT, and the average IOP lowering was about 6 millimeters of mercury with the SLT treatment. Found to be more cost effective, that's not surprising, with similar health-related quality of life outcomes. And that was the primary outcome of the study. That was the primary outcome measure. Repeatable. To my knowledge, this is really the only good study to demonstrate repeatability of full 360-degree SLT with another 360-degree treatment, and lowered the pressure, again, about 6 millimeters after about 18 months, and almost 70% of them were at target after the repeatable treatment. Peter Chang, Rich, and others from this institution looked at a large volume of eyes in the IRIS registry in 2020, 263,000 eyes that had received SLT with a baseline pressure of 19. The data was not as good as the LIGHT study. 37% had overall a 20% reduction in intraocular pressure, but you have a huge number of eyes, and that's one of the great benefits of big data, that you have an opportunity to see in real life settings what you can expect the efficacy to be in a real world setting. The problem, of course, is it's a real world setting, and it's not as clean data as it would be in a randomized controlled study, both in terms of the overall IOP data as well as other metrics. Last thing I'll talk about is angle closure, laser peripheral iridotomies for angle closure. There are two important studies, no great innovations here, but really important studies that have been published. The Zhongshan Angle Closure Prevention Trial, also known as the ZAP trial, randomized 889 eyes that had anatomically narrow angles, often referred to as primary angle closure suspects. So these are just your run-of-the-mill narrow angle patients that were followed in the province of China in Zhongshan. And they were randomized to either observation for 6 years or an iridotomy. Data published, first author he in Lancet 2019, showed that overall there were very few adverse events in the entire population. And these were Asian eyes at high risk with really narrow angles. You could see that if you looked at the events, and an event was either progression to primary angle closure or primary or acute angle closure glaucoma, there were 19 events in the eyes that received a peripheral iridotomy. There were 36 events in the eyes that were randomized to observation, and that was statistically significant. But if you look at the overall volume of patients, you can see this is a rather rare occurrence, even in eyes deemed to be at relatively high risk with 6 years of follow-up. Interestingly, the acute angle closure cases, the most common risk factor, pharmacologic dilation when they were getting their eyes examined. Keep that in mind. Interestingly, in a separate publication, there's a typo there. That wasn't 2000, that was 2021. That came out last year, and it referred to the location of the iridotomy. And there's always been discussion amongst glaucomatologists about whether or not the ideal preferred location should be nasal or temporal along the horizontal meridian, or whether it should be located under the upper eyelid at the superior location. Nathan Congdon reported in 2012 that he found, surprisingly, that the really was no difference whether you did it horizontally along the horizontal meridian or superiorly. What the investigators of the ZAP trial found was that actually, again, superior location offered an anatomic advantage, that there was greater angle widening by spectral domain OCT in the eyes that actually had a superior PI location compared to a horizontally oriented iridotomy. Many of us have always felt that if the position of the iridotomy bifurcates the position of the upper eyelid, that there could be some refractive prismatic effects caused by the tear film, and patients would then have a higher likelihood of having a negative dysphotopsia associated with that, where they might see an arc of light. That did not necessarily pan out in any of these two big publications. Eagle trial, again, published in Lancet 2016, a really important study, randomized a different group of people. These are not the suspects. These are not just narrow angles. These are primary angle closures. That is to say, they have either elevated intraocular pressure, or they have glaucoma, or they have peripheral anterior synechia, but they're not just isolated narrow angle suspect. These eyes were randomized either to an initial peripheral iridotomy or lens extraction, not cataract extraction, because they didn't have visually significant cataracts. And after 3 years of follow-up, why they showed that the eyes randomized to lens extraction had about 1 millimeter of mercury lower pressures, that there was, again, a significant cost effectiveness, cost advantage, and improved quality of life scores with the group that received lens extraction, many of which of those findings relate to the fact that 20% of the lens extraction group required glaucoma medications compared to 60% in the peripheral iridotomy. So very important studies. Are they medical breakthroughs in glaucoma? I'd have to say no. And, you know, that's really, you see, I narrowed it down to 3 bullets, Doug. I probably should have just taken out the first 2 and left you with the last, but it's hard to beat a prostaglandin analog. These are novel therapeutics. These are novel innovations in laser technology. There are clearly no breakthroughs. Unmet needs continue to exist, the greatest of which is drug delivery, in my estimation, because of the problems that we all face with compliance. And I once asked Dr. Becker, Bernie Becker, what he felt to be one of the greatest disappointments in his lengthy career treating patients with glaucoma. And he said, all we do is treat eye pressure. And after so many decades, that's still what we do. We lower the eye pressure because it's the only modifiable risk factor. So there's a great need for neuroprotection and neuroregeneration, and we just don't have it yet. So with that, I'll conclude. Again, Doug, thank you for all you've done in training generations of and inspiring generations of ophthalmologists to practice glaucoma. And we're here to honor your legacy and lifetime achievements.
Open it up.
Yeah.
Questions. One quick question. Like we talked about, you know, some of the newer medications and the frustration that I think we all feel, right? That is really access. You know, so often we're stuck with generic latanoprost, generic, you know, well, Timolol, generic Cosap, et cetera. Whereas you look at the ROCK inhibitors, et cetera, and it's so often it's the insurance companies that dictate what our patients are able to get. How do you kind of work around that other than just chronically doing prior authorizations, et cetera?
Worked in Palm Beach.
His patients don't have to worry about that.
You know, you write a prescription. It's gotten better, first of all. You know, the prior auths have gotten better. They're still really, really challenging, but you can almost bet you'll get a phone call. We don't have samples. The University of Miami has a strict no sample policy. So that having been said, you will get a phone call. The drugs are expensive, hundreds of dollars for a single month. You have to ask yourself, and this was really nicely pointed out by Elizabeth, you know, there is a cost to care, and is the benefit that you're receiving from a branded product worth the cost of care of that branded product? Generics do a pretty, it's hard, like I said, it is hard to beat generic latanoprost.
Any other comments? Go ahead.
All right. So can you just briefly mention the COAST trial and you know, and the idea of SLT as being a default first-line therapy, given the issues of compliance, you know, all that.
You mean the light trial?
No, the COAST trial. That's the trial that Tony Riolini and Gus Guzzard and the NEI that's looking at low dose, low energy SLT with the idea of repeating it on a yearly basis, like touch up no matter what.
Yeah, I think from a compliance perspective, if you're, it was in St. Lucia, I believe, right? So Tony's NEI sponsored study is treating a group of people in St. Lucia and watching them over a period of time. Oh, the coast is US? Okay. So from a compliance perspective, there was an old phrase that Paul Kaufman introduced called fire and forget. And that's laser trabeculoplasty. And the reason it's referred to as fire and forget is because it's that easy. You don't have to think about compliance. It works. GLT study showed it works. Low energy SLT is a great thing. And, if it was my eye, I would probably opt for a prostaglandin analog. And if it worked and it was well tolerated, I would do that because I think it's a really, really effective therapy. Second choice for my eye would be SLT. And I think that the two in tandem is fantastic. But I think that is addressing the compliance issue. And that's the reason why Paul referred to it as fire and forget.
I understand that the Eagle Vision, their device is going on, they got a CE mark in Europe and it's going on sale, I think, this month. So it would be, interesting if it works.
I'm struck by the difference between the light study trial and that Chang study that you referenced, the 20% IOP, you're trying to 36% got 20% IOP reduction. Was that over a longer period of time? That iris registry, that may explain why the difference.
Rich, do you know what the follow-up in Peter's?
Was it from a treated baseline versus
It was
primary
from the
therapy?
treated baseline.
That's different.
So they may have been, they were likely on.
Light was 3 years. I don't know the follow-up in Peter's study, but it's, they're different studies. It's a real world study.
Peters wasn't exactly studied.
Yeah.
Yeah, it was statistical.
It's data mining from the iris registry.
Yeah.
It's different than a study.
Right.
Most of those were already on some type of topical therapy, likely.
I'm sure they would. Yeah.
I just have a question theoretically. We seem to know now from GATT and some of the other things that are done that they don't work very well in people who've had glaucoma for a long time who've been on aqueous suppressants. And I wonder if the collector channels atrophy if you have either less fluid going into the eye or you have it going out through the uveoscleral pathway. And so as I think about a primary therapy for glaucoma, there might be an advantage to improving outflow through the trabecular meshwork and keeping those channels going theoretically. And also the prostaglandins, of course, do have some effect on the conjunctiva when it comes to having surgery later on, and probably the benzalkonium chloride does as well. So I think Elizabeth has started an SLT clinic for the residents that I staff, and pretty convinced that it probably is from compliance and some theoretical reasons of not doing something to the conjunctiva, which I might want to operate on later or have operated on if it's me, of having a laser treatment rather than the prostaglandin. So it's theoretical, but I wonder what your thoughts might be about that.
I remember being on a panel, this is late 90s, and there was 10 of us on the panel, and the moderator just went across the line at that time, if we had glaucoma, how we would want to be treated ourselves. And the vast majority said medication, and one or two said laser. This was, there were some GLT investigators. And they said, you were a GLT investigator. You just said, you showed the data, we discussed the data, and yet you would rather have medication despite the benefits. It was about a point better in the GLT laser versus medication. My feeling is similar to Elizabeth's. You know, if you were to offer your patients one versus the other and describe the data, the vast majority still kind of prefer medication. In my experience, that's, I guess, your experience as well. Not all, but there are some very, very convincing, strong arguments to be made about not touching the conjunctiva with compounds over the long period of time. And maybe the things that you mentioned also on the TM and the collector channels also play into that. So yeah, I think it is, the data is there in 2 studies.
Just a quick comment. Some years back, when Francisco Fontes was alive, at a meeting where we had little clicky response things, this was community doctor meeting. He asked the question of, what do you offer your patients for initial glaucoma treatment? And the choices were drops, laser, and incisional surgery. And the answer was just like teeniest bit laser, almost, and all the rest were drops. Nobody started with incisional surgery. A couple questions later, he said, what would you do if you had glaucoma? What would your initial treatment be? And although drops was still the highest, there was a big increase in laser. So we had a large number of doctors who were not recommending what they themselves would choose to do.
Yep. One last question in the back, and then we'll move
Based
on.
on the ZAP study, I'm curious on your recommendations of, do we do LPIs on these patients at risk for angle closure, or do we just watch them and warn them about the symptoms?
Oh, you send it to somebody else and let them decide. This is why you don't want to have the laser sometimes.
Yeah, I think it's fair to say we probably overtreat the vast majority of patients, and that you have to target those patients that need it the most, based on their risk stratification, the amount of appositional closure that exists, their age, et cetera. So.
All right. Before Steve Getty comes up, because you're up next, let me, as we're honoring Dr. Anderson, one of the stories I wanted to share. When I had first started, I finally had a chance to work with Dr. Anderson in his clinic. It took some years before you got a chance to work with some of these more senior glaucoma guys. And the one thing that was always great about Dr. Anderson was whenever, you know, you saw a new patient and worked it up, a few days later, you would find in your mailbox, he would type the letter and actually made sure that you got a copy of the letter that he sent to the physician, which, you know, kind of told you everything. You know, you were the one doing the workup, you were the one doing gonioscopy, making impressions and plans. And, you know, and sometimes you would agree, sometimes you would disagree, but it was just his thoughtfulness of making sure that, you know, you were able to kind of find out what happened to that patient, I think was really remarkable and really one of the exceptions of people who did that. So the year I'd spent with him, and obviously the friendship that over the years of being around him has really been tremendous. And so with that, let me turn gears to Steve Getty. Steve is a professor in ophthalmology. He holds the John Clarkson Chair in Ophthalmology, and he's the Vice Chair of Education. Steve ran the ophthalmology residency for many, many years before he gave that up. You know, the one thing about Steve was, you know, he's been around for quite a long time. John and I have interacted with Steve over and over. And even when our optometry residency program had started in the mid-90s, and, you know, our residents would go to some of the conference, they weren't always, you know, always welcome in some of the conferences. Sometimes it would be pretty contentious about should they be in or should they not. And as Steve being head of the program, he was always into teaching. And always wanted to make sure that our residents and our students were always welcome to be in those sessions. And you know, he always kind of had our back, you know, really always. And he's been really just kind of a great friend. I remember when Steve was a fellow, and you know, he was around for a long time too. And the one thing about Steve being from Illinois, I think I have that right, Steve. There is not a nicer person than you could ever meet. And in fact, you know, the first few times that I met Steve, I'm like, you know, there's nobody. He's faking it. I mean, there's nobody this nice. And you know, time like, gosh, he's just so nice. And you know, fast forward 20 plus years or whatever it's been, Steve is still the nicest person you could ever meet. He's just really a gentleman, and he's always been a great teacher. So with that, Steve, let me turn the podium over to you. Thank you.
Well, Mark, thanks so much for that very kind introduction. And thanks to Mark and Murray and Mike and John for really organizing an outstanding program and for inviting me to participate. I was asked to discuss glaucoma surgical care with a focus on changes in the last decade. I have no financial interest in the subject matter of this presentation. You know, I'm particularly pleased to be part of this meeting because it honors Doug Anderson, and Dr. Anderson has been a wonderful mentor to me, as well as a great friend and a great colleague over the years. It's hard to imagine any single individual that has contributed more to the field of glaucoma and has had a greater impact on the care of glaucoma patients worldwide. And I'm certainly not alone in my admiration for him. And I just wanted to start by sharing some quotes from other glaucoma specialists who Dr. Anderson has mentored over the years. So Art Schwartz described Doug Anderson as a man with an amazing intelligence and a genuine modesty. He has the ability to make the complex understandable. A great clinician, researcher, mentor, and friend. His abilities and contributions to our knowledge are an international treasure. When Doug Anderson speaks, the room quiets and everybody listens. Here's another quote from Harry Quigley. We heard one earlier during David's presentation. After 2 years working with Doug Anderson, I have tried to emulate his ability to be a curious scientist when performing clinical ophthalmology, and his ability never to lose the sensitivity of the human interaction with a person on the other side of the slit lamp. Doug had a good sense of distinguishing the known knowns, the known unknowns, and the unknown unknowns, and deciphering the basis of our care decisions. Dale Hoyer stated, whether with respect to patient care or research, Doug's approach was consistently thoughtful and reflective, steeped in wisdom and intentionality. Lee Allward said, there are so many in our world for whom new knowledge is a competition. Doug taught us all that it is a collaboration and that we should take joy from everyone's successes. Phil Chen stated, Doug has always struck me, even more as the years have gone by, with his clarity of scientific thought, his deep understanding of ocular physiology, and his gentlemanly approach to personal interaction. Here's a quote from Kuldev Singh. Amongst Doug's many wonderful qualities, the one which I most appreciate is his openness to changing any long-held belief if the evidence suggests that it is not correct. While others may passionately torture the data to make it fit with how they see the world, Doug is completely objective on every issue. And this objectivity is, in my opinion, the attribute which makes him truly unique amongst scientific contributors and educators in our profession. And lastly, Greg Skuda had this message for Doug. Doug, no words can fully capture the great professional respect and personal affection that all of us who trained at Bascom Palmer have for you. However, please know that you have been and always will be a shining example and constant inspiration in every way, that we have been blessed to walk beside you. So thanks to Doug for his for his amazing contributions to glaucoma, including glaucoma surgery. And again, I've been tasked with the discussion of changes in glaucoma surgery. And certainly the biggest change over the past decade has been an exponential increase in the surgical options that are available to manage the disease glaucoma. Now, traditionally, incisional glaucoma surgery has involved trabeculectomy and tube shunt surgery. And these traditional glaucoma procedures have been around for really more than a half a century in their current form. I would put the Express implant in this category. I think this device should be considered an adjunct to trabeculectomy. So non-penetrating glaucoma surgery was introduced as a less invasive alternative to trabeculectomy, and deep sclerectomy, viscocanaloplasty, and canaloplasty are under this category. Endoscopic cyclophotocoagulation, or ECP, is an incisional glaucoma procedure that involves a targeted destruction of ciliary processes under direct visualization. But really, the explosion in glaucoma surgery over the last decade has occurred with the introduction of minimally invasive glaucoma surgery, or MIGS. And there are several procedures that fall under this category. And I'm going to discuss all of these procedures, which are ones that are currently available to glaucoma surgeons in the United States. So trabeculectomy was really popularized in the late 1960s by Cairns. And this procedure involves the dissection of a partial thickness scleral flap that's hinged at the limbus. We then remove a block of corneal scleral tissue underneath that flap and then reapproximate the scleral flap to the scleral bed using interrupted tenonylon sutures. And the number of flap sutures and their tension really controls how much flow occurs through that scleral fistula. And if the operation works properly, there's some aqueous collection in the subconjunctival space, producing a filtering blood, as we all know. Glaucoma surgeons can actually cut those sutures in the scleral flap selectively to titrate down the intraocular pressure postoperatively. And that means trabeculectomy is a titratable glaucoma operation. In fact, it's the only titratable glaucoma operation. And I think that's an underappreciated advantage of trabeculectomy. Antifibrotic agents, namely mitomycin C and 5-FU, have been shown to improve the success rate of trabeculectomy. Unfortunately, they also increase the risk of complications like hypotony and bleb complications. And I think a growing concern about those bleb-related complications, in particular leaks, infections, dysesthesia, has prompted many surgeons to look towards alternative surgical approaches. Pencaw described a variety of modifications in trabeculectomy technique that he's termed the Moorfield Safer Surgery System. This includes use of a fornix-based conjunctival flap, a more diffuse application of mitomycin C, limiting the side incisions of the scleral flap to try to promote a more posterior direction of aqueous flow postoperatively, and IOP titration intraoperatively with tensioning of the flap sutures, also to encourage a posterior flow postoperatively. And these techniques are designed to improve success and minimize the risk of complications associated with trabeculectomy. The Express implant's a non-valve stainless steel tube. And when this device was first introduced, it was really a disaster, if you ask me. There was a really high rates of hypotony and extrusion associated with it. Subsequently, it was determined that it's best placed underneath the scleral flap and really negates the need for a sclerostomy or iridectomy, but really augments a trabeculectomy in my mind. And with that modification and technique, really markedly reduced the risk of hypotony and extrusion. A randomized clinical trial found similar long-term safety and efficacy with the Express implant compared to trabeculectomy. And here's the results of that randomized clinical trial, the XVT study, which took patients and randomly assigned them to a standard trabeculectomy or Express implant, both with adjunctive mitomycin C. And you can see there was no difference in the rate of surgical success and no difference in mean intraocular pressures during 2 years of follow-up. There was a more rapid return of visual acuity back to the preoperative level in the Express group compared to the trabeculectomy group, but there was no difference in visual acuity outcomes after 2 years between the two groups. Tube shunts share a common design consisting of a silicone tube that is connected to an end plate. The tube is generally inserted into the anterior chamber, although you can actually put it in the ciliary sulcus in pseudophakic eyes, or even through the pars plana into the vitreous cavity in an eye that's had a complete pars point of vitrectomy. The tube will shunt aqueous humor to the end plate, which is located in the equatorial region of the globe. The end plate promotes the formation of a non-adherent capsule around it so that when flow occurs through the device, aqueous actually pools in the potential space between that end plate and the surrounding capsule. And then aqueous will pass through the capsule through the process of passive diffusion and is absorbed by periocular capillaries and lymphatics, and that's how it lowers intraocular pressure. Tube shunts can be subdivided into valved and non-valved shunts, depending on whether or not incorporated in the design is a valve-like mechanism, which will limit flow through the device if the pressure goes too low, usually less than 8 or 10 millimeters of mercury or so. Traditionally, tube shunts have been used in eyes at high risk for filtration failure, but I think the indications have been progressively expanding over time. There have been several multi-center randomized clinical trials that I think have provided valuable information relating to tube shunts. And two of those studies are the Ahmed Berivel comparison or ABC study and Ahmed versus Berivel study or AVB study. These two trials are remarkably similar in their design and actually remarkably similar in their results. And I think that has allowed one trial to validate the other. Both studies enrolled patients that were undergoing tube shunt surgery as their planned surgical procedure, and patients were randomized to receive an Ahmed SP7 or a 350 Berivel implant. There was analysis of pooled data from both the ABC and AVB studies that was recently published, and it showed a higher success rate with the Berivel implant compared to the Ahmed implant, and lower mean pressures in the Berivel group compared to the Ahmed group. And that's likely related to the larger surface area of the Berivel implant compared to the Ahmed implant. Here are complication data from those studies. In the ABC study, the rate of early postoperative complications, defined as complications occurring in the first 3 months postoperatively, and serious complications, defined as complications requiring a reoperation to manage a complication or producing loss of 2 or more lines of spell and visual acuity. The rates of early and serious complications were higher in the Berivel group compared to the Ahmed group. The rate of late postoperative complications occurring after 3 months was not different between the two groups. And in the AVB study, the rate of vision-threatening hypotony-related complications was higher in the Berivel group. So both studies suggested that the safety profile actually favored the Ahmed implant over the Berivel implant, likely related to the valve mechanism incorporated into the design. You know, we're seeing some interesting trends in glaucoma surgery, and this is information based on Medicare claims data. It shows the number of trabeculectomies and tube shunts implanted during a 23-year period. This data was published by Dr. Romelu and colleagues at Baltimore, and more recent data published by Dr. Rathi and Dr. Greenfield. And it shows that over the last more than 2 decades, there's been actually a steady decline in the number of trabeculectomies being performed. This is likely related to advances in medical therapy. I think most notably the introduction of prostaglandin analogs in the mid-1990s, and also the later introduction of alternative surgical procedures. But what's interesting is during the same time period, the number of tube shunts has actually been steadily climbing, and there's actually been a roughly 6-fold increase in the number of tube shunts during this period. Now, trabeculectomy continues to be a more commonly performed procedure than tube shunt surgery, but the shift in practice patterns, I think, is obvious here. Surveys of the American Glaucoma Society membership have shown similar shifts in practice patterns. The first survey was conducted by Rich Parrish and Phil Chen in 1996, and it presented a variety of clinical scenarios to glaucoma surgeons and asked, what is your preferred surgical approach? The same survey was repeated in 2002, 2008, and in 2016. And you can see the proportion of glaucoma surgeons selecting trabeculectomy as a preferred approach actually steadily declined in all of those clinical scenarios, and there was a concurrent increase in the popularity of tube shunt surgery. There have been a couple of studies that have actually compared the two traditional glaucoma surgeries, namely trabeculectomy and tube shunt surgery. The first was a TVT study. It enrolled 212 patients with prior cataract extraction or failed filtering surgery and randomized them to receive a 350 Bierveld or trabeculectomy with mitomycin C. And the cumulative probability of failure through 5 years of follow-up was higher in the trabeculectomy group compared to the tube group. And here's information relating to complications. The rate of early complications occurring in the first month after surgery was significantly higher in the trabeculectomy group, but there was no difference between the two groups with respect to complications occurring after a month or complications requiring a reoperation or producing vision loss. A study similar in design, but enrolling a different population, was a primary tube versus trabeculectomy study, which enrolled patients without any prior incisional ocular surgery. And again, randomized them to a 350 Bierveld or trabeculectomy with mitomycin C, although a lower dosage of mitomycin C was used in the PTVT study compared to the TVT study. In contrast to the TVT study, the PTVT study actually showed a higher failure rate with tube shunt surgery than trabeculectomy. That difference was statistically significant at a year, but not at 3 years or 5 years. Like the TVT study, the rate of early postoperative complications was higher following trabeculectomy, but no difference in the rates of late and serious complications. The PTVT study did a risk factor analysis to try to look at baseline factors that would predict failure. And it turned out that only preoperative intraocular pressure was significantly associated with failure. In particular, having a lower preoperative intraocular pressure increased your risk of failure. And this is actually shows that a significant treatment interaction was seen between preoperative intraocular pressure and failure. And in this analysis, this post hoc analysis, we subdivided the study population into rough tertiles based on preoperative intraocular pressure. And what you see here is that there was an inverse relationship between preoperative pressure and failure in the tube group, whereas in the trabeculectomy group, failure was less influenced by preoperative intraocular pressure. As a result, at low levels of preoperative intraocular pressure, was a much higher failure rate in the tube group compared to the trabeculectomy group. But that relationship reversed at higher levels of pressure. There was actually a lower failure rate in the tube group compared to the trabeculectomy group. This actually prompted us to go back and look at the TVT study data. And you can see something similar and also interesting, that the treatment benefit of tube shunt surgery over trabeculectomy was greater at higher levels of preoperative intraocular pressure. So I think both the TVT and PTVT studies show that the relative success of tube shunt surgery and trabeculectomy really depends on whether or not the patient had prior incisional ocular surgery. In particular, in the TVT study, we saw a higher success rate with tube shunt surgery in eyes that had prior surgery. And in the PTVT study, we saw a higher success rate with trabeculectomy, or at least a trend in that direction in eyes that didn't have prior ocular surgery. And that's certainly consistent with the conventional teaching that you ought to look at and see if an eye's had prior ocular surgery. That should influence your surgical decision-making. What it also showed that preoperative intraocular pressure influences the relative success of trabeculectomy and tube shunt surgery. In other words, in both TVT and PTVT, the performance of tube shunt surgery relative to trabeculectomy is better at higher levels of pressure, and the performance of trabeculectomy relative to tube shunt surgery is better at lower levels of pressure. And one thing that these studies have taught me is I think preoperative intraocular pressure is another important consideration when picking between the two traditional glaucoma surgeries that are available, namely trabeculectomy and tube shunt surgery. Let's shift gears and talk a little bit about non-penetrating glaucoma surgery. These procedures are designed to avoid a direct communication between the anterior chamber and subconjunctival space, thereby reducing the risk of hypotony and blood-related complications. These procedures are technically more difficult than trabeculectomy and seem to be more popular in European countries actually than in the United States. Deep sclerectomy, viscocanalostomy, and canaloplasty are the procedures that fall under the category of non-penetrating glaucoma surgery. So deep sclerectomy involves excising a block of corneal scleral tissue underneath a scleral flap, but leaves intact a window of Descemet's and trabecular meshwork to provide resistance to aqueous flow. Randomized clinical trials have demonstrated, at least one has demonstrated that trabeculectomy is more effective than deep sclerectomy. There are other trials that have shown equivalence between the two procedures, and it is commonplace to use adjunctive antifibrotic agents and even collagen implants as pictured here with deep sclerectomy. Here's a trial from Romania that enrolled a relatively small number of patients, but showed a higher success rate and lower mean pressures with trabeculectomy compared to deep sclerectomy. Viscocanalostomy is deep sclerectomy with the addition of expansion of a segment of Schlemm's canal with a viscoelastic agent. Randomized clinical trials have suggested greater pressure reduction with trabeculectomy, but a lower risk of complications with viscocanalostomy. And here's one of those randomized clinical trials, again, showing higher success and lower mean pressures with trabeculectomy compared to viscocanalostomy. Canaloplasty is deep sclerectomy plus circumferential dilation of Schlemm's canal with a flexible microcatheter and also placement of a tenoproline tensioning suture to keep the canal of Schlemm open. There have been no randomized clinical trials comparing canaloplasty to trabeculectomy, but a retrospective case comparison study found lower pressures with trabeculectomy compared to canaloplasty. And here's a study published by Ramesh Ayala. And among patients that were not on any adjunctive medical therapy, you can see there are lower mean pressures in the trabeculectomy group compared to the canaloplasty group, and that those differences were statistically significant at multiple time points, including at a year's follow-up. Endoscopic cyclophotocoagulation, or ECP, involves laser photocoagulation of ciliary processes under direct endoscopic visualization. This is a procedure that's typically performed in combination with phacoemulsification and has been shown to produce moderate long-term pressure reduction. I think the biggest problem with this procedure is cystoid macular edema, which is not an uncommon complication associated with it, and the most common cause of vision loss associated with ECP. As I mentioned earlier, the real explosion that has occurred in glaucoma surgery over the last decade has been with the introduction of minimally invasive glaucoma surgery, or MIGS. This is a term that was coined by IGAMED and refers to a group of newer glaucoma procedures that share several characteristics, including an ab internal approach, minimal trauma to ocular tissue, allowing for a more rapid post-operative recovery, really an excellent safety profile, but unfortunately, generally produce only modest pressure reduction. These procedures are frequently performed in combination with phacoemulsification, and they are unquestionably growing in popularity. The first generation trabecular microbypass stent, or iStent, is a snorkel-shaped device that's inserted into Schlemm's canal. It was approved by the FDA for implantation in combination with cataract extraction in patients with mild to moderate glaucoma. Randomized clinical trials have shown greater reduction in pressure and in adjunctive medical therapy with a phaco iStent compared to phaco alone. And there's evidence to suggest that implanting multiple stents can be more effective than implanting just a single stent. The US iStent study is a multi-center randomized clinical trial comparing phaco alone versus phaco with implantation of an iStent in patients with mild to moderate glaucoma. And patients were randomized into those two treatment arms in a 1-to-1 ratio. The primary outcome measure in this study was having an intraocular pressure less than 21 on no medical therapy. And the secondary outcome measure was having at least a 20% reduction in pressure from baseline on no medical therapy. And both of those outcome measures favored the phaco iStent group over the phaco group at a year. The iStent Inject is a thumbtack shaped device pictured here that's inserted into Schlemm's canal. The head actually resides in Schlemm's canal. The thorax is in the trabecular meshwork, and the flange sits in the anterior chamber. 2 stents are preloaded in the injector and are placed about 2 to 3 clock hours apart in this procedure. And this device was approved by the FDA for use in combination with cataract surgery in patients with mild to moderate glaucoma. The iStent Inject study was a multi-center randomized clinical trial evaluating the safety and efficacy of the iStent Inject in combination with cataract extraction. Enrolled 505 eyes with mild to moderate open-angle glaucoma and randomized them in a 3-to-1 ratio to the phaco iStent group or phaco alone group. You can see the proportion of eyes that achieved at least a 20% reduction in pressure after a washout was significantly higher in the phaco iStent group than the phaco alone group. And the degree of pressure reduction after washout was greater in the phaco iStent Inject group compared to the phaco group alone. The Hydrus microstent is an 8mm nitinol scaffold that's inserted into Schlemm's canal. The FDA approved it for use in combination with cataract surgery in mild to moderate open-angle glaucoma, and a randomized clinical trial showed greater reduction in pressure and greater reduction in medical therapy with a Hydrus implant in combination with phaco than phaco alone. That study was called the Horizon study, enrolled over 500 patients, randomized them to a phaco Hydrus, to a phaco alone in a 2-to-1 ratio. And again, the proportion of patients that achieved a 20% reduction in pressure after washout was significantly higher in the phaco Hydrus group compared to the phaco alone group at a year and 2 years. And there was also a greater reduction in intraocular pressure after washout in the phaco Hydrus group compared to the phaco alone group. Just a couple of months ago, the 5-year data from the Horizon study was published. You can see there was no actually difference in mean intraocular pressures between the phaco Hydrus group and the phaco group, but less medical therapy was required in the phaco Hydrus group. There was no significant difference in corneal endothelial cell density between the 2 groups. And you can see down on the lower part of the slide, the cumulative probability of requiring repeat incisional glaucoma surgery was higher in the phaco alone group compared to the phaco Hydrus group. So the COMPARE study is actually the first randomized clinical trial comparing 2 MIGS devices as standalone procedures. And it enrolled 152 patients and randomized them to either receive a Hydrus microstent or 2 first-generation iStents. Preoperative intraocular pressure was in the high teens, and after a washout went up to the upper 20s, and after surgical treatment settled again in the high teens, not so different from the preoperative level, however, with a significant reduction in medical therapy. That reduction in medical therapy was greater in the Hydrus group compared to the iStent group, suggesting greater efficacy of the Hydrus implant compared to first-generation iStents. Here's survival curves. You can see there was a relatively low rate of surgical success in both study arms, success being defined as a pressure less than or equal to 18 without any medical therapy. Although the success rate was higher in the Hydrus group compared to the iStent group. Trabectome is a device that performs electrocautery to remove a strip of trabecular meshwork and inner wall Schlemm's canal. A meta-analysis of 14 studies involving over 5,000 patients showed that the mean reduction in intraocular pressure was about 31%, and the mean success rate after 2 years was about 66% in that meta-analysis. A retrospective comparison of trabectome to trabeculectomy showed that trabeculectomy was a far more effective procedure in lowering intraocular pressure. And here are results from that retrospective multi-center comparative study. And you can see the cumulative probability of failure was much higher in the trabectome group compared to the trabeculectomy group. The Cahook dual blade is a single-use ophthalmic blade that removes trabecular meshwork in the inner wall of Schlemm's canal. The blade is composed of a pointed tip that's used to pierce the trabecular meshwork. It has a ramp that elevates and stretches the trabecular meshwork. The dual blade actually is what excises the strip of trabecular meshwork, and a foot plate is designed to prevent collateral damage to other ocular tissue. There was a randomized prospective study comparing a goniotomy using a Cahook dual blade to iStent implantation, both in conjunction with phacoemulsification. Mean pressures were actually lower in the Cahook dual blade group compared to the iStent group. That difference was statistically significant at a day and at a month. Both procedures reduced the need for adjunctive medical therapy, although there was a greater reduction in medical therapy in the Cahook dual blade group compared to the iStent group, although the differences were not statistically significant. The definition of success in this study was getting a 20% reduction in intraocular pressure or reducing the need for medical therapy by one medication. And using that definition of success, there was actually a significantly higher success rate in the phaco Cahook dual blade group compared to the phaco iStent group. So GATT and TRAB 360 are very similar procedures. They involve use of a catheter or a suture that is inserted into Schlemm's canal and actually pulled into the antechamber to perform a trabeculotomy. The GATT uses an illuminated microcatheter or a suture that's past 360 degrees, whereas TRAB 360 uses a polymer injection tube that is past 180 degrees. The catheter is then withdrawn back into the device. It is rotated and the other 180 degrees can be treated. Both procedures allow performance of a 360-degree trabeculotomy via an ab internal approach. There was a retrospective study comparing GATT to trabeculectomy. They found no significant difference in surgical success rate, but mean intraocular pressures were lower in the trabeculectomy group and the need for medical therapy was significantly lower. Ab internal canaloplasty and Visco 360 are similar procedures, both involving a microcatheter that is inserted in the Schlemm's canal and used to inject viscoelastic circumferentially to dilate Schlemm's canal. And this is designed to improve circumferential flow of aqueous outflow. Ab internal canaloplasty uses an illuminated microcatheter past 360 degrees, whereas Visco 360 uses a polymer injection tube past 180 degrees and then removed and repeated in the opposite direction. CyPass, a flexible 6.3 millimeter fenestrated microstent that's inserted into the suprachoroidal space through a guide wire. The pressure gradient drives aqueous humor through the device from the anterior chamber into the suprachoroidal space, and this device was approved for implantation in combination with cataract extraction in patients with mild to moderate glaucoma. A randomized clinical trial showed that it produced better pressure reduction than phaco alone. And that study was called the COMPASS trial, enrolled 505 patients and randomized them to a phaco-CyPass or phaco alone in a 3-to-1 ratio. You can see the proportion of patients that achieved at least a 20% reduction in pressure after washout was higher in the phaco CyPass group compared to phaco alone group at a year and 2 years. And the degree of pressure reduction after washout was greater in the phaco CyPass group compared to phaco alone group. As most of you are aware, in 2018, Alcon announced a voluntary withdrawal of CyPass from the marketplace. This was related to a greater loss of corneal endothelial cells in the phaco CyPass group compared to the phaco alone group. And that was not evident at a year or 2 years, but with longer follow-up became apparent. There was also a loss of efficacy of CyPass over time that I think contributed to its withdrawal. The Zen gel stent is a 6mm tubular collagen implant that's placed translimbally using a 23 gauge needle inserter. It drains fluid into the subconjunctival space, much like trabeculectomy does. One of the shortcomings of this procedure is that it does seem to have a high rate of needling that is required to allow the device to continue to function. Earlier studies show up to a third to half of patients require needling procedures. A retrospective comparative study found similar efficacy with a Zen gel stent and trabeculectomy with mitomycin C. And here are results from that study, both looking at trabeculectomy compared with the Zen gel stent with adjunctive use of mitomycin C as standalone procedures. And using a variety of definitions of success, similar efficacy was demonstrated with both procedures. So we just went through a bunch of MIGS trials, and they have a similar design of comparing a MIGS device in combination with phaco compared to phaco alone. And most of those trials, with the exception of the US iStent trial, included a washout, which better is able to discern what the added benefit of a MIGS device is above phaco alone. And what you see that phaco alone produced about a 5.5mm reduction in pressure, which translates to about a 20% reduction in pressure from baseline. And it's really amazingly consistent across these different MIGS trials. Implantation of a MIGS device provides about another 2 millimeters of pressure reduction, or on average about a 10% additional pressure reduction from baseline. So in other words, about 2/3 of the pressure reduction you get with phaco MIGS procedures is provided by the phaco part of the operation, and about 1/3 is provided by the MIGS procedure. And that additional pressure reduction that is provided by the MIGS is highly statistically significant above phaco alone. Here's similar data related to medical therapy. You can see phaco alone results in reduction in about 1 medication postoperatively, and the addition of a MIGS device adds about a 1/2 medication additional reduction in medical therapy. Again, about 2/3 of the reduction in medical therapy that you see with phaco MIGS procedures is provided by the phaco part of the operation, and about 1/3 provided by the MIGS procedure. And that reduction in medical therapy with the added MIGS device is highly statistically significant. But we know that phaco tends to reduce intraocular pressure in patients with glaucoma, and actually it can reduce pressure in patients with ocular hypertension. In fact, here's information that came from the ocular hypertension treatment study showing that on average, phaco produced a significant and sustained reduction in intraocular pressure. So in conclusion, the surgical options for managing glaucoma have expanded exponentially in recent years. Traditional glaucoma surgery, that's trabeculectomy and tube shunt surgery, continues to be the most effective procedures to reduce intraocular pressure. but unfortunately, they are associated with greater risks. Tube shunts are being utilized with increasing frequency as an alternative to trabeculectomy, I think mainly related to concerns about blood-related infections. MIGS definitely offer a more favorable safety profile compared to traditional glaucoma surgery, but they provide only modest pressure reduction. And I think selection of a glaucoma procedure really involves weighing the risks and benefits for an individual patient. Unfortunately, with our current glaucoma surgical options, there seems to be a trade-off between safety and efficacy. And what we really need, in my opinion, is a procedure that offers the efficacy of traditional glaucoma surgery, but the safety profile of MIGS. But that is not available at the current time. In my opinion, traditional glaucoma surgery is still the most desirable procedure in patients with advanced glaucoma and/or progressive glaucoma. MIGS may be bridging the gap between laser trabeculoplasty and our traditional glaucoma operations. And finally, cataract surgery alone is really effective in lowering intraocular pressure in patients with ocular hypertension and glaucoma, and we ought to keep that in mind in our surgical decision-making. So I'm finished, Alex. So thanks, and happy to answer any questions. Yes.
So as far as a new untreated advanced disease patient that is initially presenting to you, considering the overall success of incisional surgical procedures with a baseline higher intraocular pressure, are you more likely to, and the TAG study also, are you more likely to move to an incisional procedure earlier rather than medication and titration upwards of medication initially?
What a great question. What a great question. And it's been said multiple times in prior lectures that in a patient with newly diagnosed glaucoma, we're really talking about the options of initial medical therapy versus initial laser trabeculoplasty. But we kind of dismiss the possibility of initial glaucoma surgery, which is what I think you're asking about, despite the fact that there's abundant evidence to support that initial surgical treatment can be perhaps a even more desirable approach to treatment of patients with glaucoma. That evidence comes from the Moorfield's primary therapy trial, which is a much older study, but took patients with newly diagnosed glaucoma, randomized them to initial medical therapy, laser trabeculoplasty, or trabeculectomy, and found that the degree of pressure reduction and success rate was highest in the trabeculectomy group, followed by the laser trabeculoplasty group, followed by medical therapy group. I think that study prompted another multi-center randomized clinical trial. And I know my hero, Dr. Palmer, is going to be talking about randomized clinical trials a little bit later, but that was the collaborative initial glaucoma treatment study, which did not have a laser arm to that study, but randomized newly diagnosed glaucoma to initial medical therapy or initial surgical treatment. I don't know if Dr. Palmer is going to discuss the results of that fully, but there, in essence, after 5 years of follow-up, was not a big difference in outcomes between the medical treated group and the surgically treated group. And as a result, it really didn't produce a great paradigm shift in our treatment of glaucoma. However, with longer follow-up in that study, more patients got worse, and it turned out among patients that had moderate to severe glaucoma at baseline, they actually did better with initial surgical treatment compared to medical treatment. And then you referred to the TAG study done in the UK, which is a newer study. It was more of a pragmatic study, but also comparing initial trabeculectomy and initial medical therapy in patients with advanced glaucoma, and suggested a benefit of initial surgery over initial medical therapy. So there is really compelling evidence from randomized clinical trials to suggest the benefit of initial surgery. Having said that, I can't think of a time when I, exactly as Elizabeth was suggesting, offer initial surgery to a patient. And maybe that means I'm not practicing evidence-based medicine because I just laid out a wealth of evidence suggesting that there may be a benefit there. But the fact of the matter is that oftentimes people can respond dramatically to medical therapy, especially with people that have very high pressures to begin with. Even if you can't control their glaucoma medically, reducing pressure to some degree can make surgery safer. One of the most valuable pieces of information that came from the fluorouracil filtering surgery study is that the patients that are highest risk for suprachoroidal hemorrhage are the ones that have markedly elevated pressure and those that have a big change in pressure. So there is value, I think, in trying to reduce pressure preoperatively just to make surgical treatment safer. I will say this clinical trial data that we just talked about makes me feel more comfortable to kind of pull the trigger and recommend surgery earlier. And I think that is an additional kind of change in glaucoma surgery that has occurred over the last decade. This had 70 slides. I was there was a limited amount of information I could cram in, but I just wanted to introduce the group to all the different surgical procedures that are available.
Steve?
So great question. Couple comments.
Steve, that was a great review. Thank you so much. I mean, it is a very busy space right now in new glaucoma procedures and new devices with things coming out virtually every quarter. For us as educators, teaching our students and our colleagues across the country how to, make referrals for glaucoma procedures, both to our glaucoma specialists and glaucoma surgeons, as well as to some of our comprehensive ophthalmologists and cataract surgeons. The question is how do we have this discussion initially in our office with these patients? What do you suggest we say to them? And what type of information do you need from us? It's really difficult for us, I think, to make a recommendation for a single procedure, right? I mean, you and I would have to be on exactly the same page. And I've worked with many glaucoma surgeons and, there's different thoughts and philosophies. You need to see the angle, you need to see all the other things before you make a choice for a particular procedure. So as a general statement, what should we be doing with our patients?
So I think there are a couple of really great points and great questions tied up in there. Yeah. And really enjoyed listening to Dr. Hodap's lecture, which among the great information that was delivered was kind of ideas about when to make a surgical referral. Patients present to me all the time for an opinion about whether they need glaucoma surgery or not. They may be referred from an optometrist or an ophthalmologist or just want to get a second opinion. And I'm always happy to provide an opinion. And that decision is not always straightforward. It's not always straightforward. But when my discussions with patients center around, do they need a glaucoma operation or not? But I almost never provide a recommendation about what procedure they need unless I'm doing the procedure, because you don't want to paint a glaucoma surgeon into a corner. And what works best in my hands may be different than what works best in their hands. So I'm purposely very ambiguous. And I tell the patient, we're going to focus our discussion on whether you need an operation or not, but the surgeon that's going to do it is the one that's going to decide what kind of operation that's needed. And I would recommend kind of when you're referring a patient to kind of make similar comments and all. Yeah. Now, the decision about when to operate or not, as I mentioned, can be not straightforward. And I'm kind of talking about traditional glaucoma surgery here. And now we have a huge group of operations that are available that are being used in a different way. When I recommend traditional glaucoma surgery, it's generally because I think the risk of that person having progressive glaucoma is high enough to warrant a procedure that has not insignificant complications associated with it. In other words, the risk of the procedure is less than the risk of not doing a procedure. It is a totally different mindset with MIGS procedures. Generally, these have been largely introduced to be done in combination with cataract surgery. That's what the FDA approval is, in mild to moderate glaucoma, oftentimes with the goal of reducing medical therapy. Now, this is a completely different mindset than what I had during the first 2/3 of my career. And I wouldn't ever be thinking about doing glaucoma surgery on somebody just to reduce their need for medical therapy. But if you have a procedure that's very safe, that's very reasonable, kind of got a little, my bias is that you do need to realize that just taking out somebody's cataract can be quite effective in reducing their need for medical therapy. But there's no doubt that you get more mileage with the addition of a MIGS device. Now, most glaucoma surgeons kind of pick 1 or 2 MIGS procedures that they feel most comfortable performing. We have lots of surgeons here at Bascom Palmer that are very proficient in doing the whole range of MIGS procedures. And those folks are actually selectively pick one types of MIG procedure depending on specific patient characteristics. So that's a pretty long answer to really a great question and all. Dr. Palmer.
Yeah, I just want to answer the question about when would you consider surgery right off the bat or very close? Maybe you want to get the pressure down before doing the surgery, but you're really thinking they need surgery. George Spaeth made a very good point based on a lot of experience. If somebody has gone blind in one eye, even though you're doing surgery, you're now risking more with the second eye. If it's somebody who has not been able to deal with the healthcare system and they haven't just come from Haiti or something and now they could get it, if they've just failed the care before and gone blind in one eye, that is usually somebody you really ought to consider surgery pretty soon.
I'll just put one quadrant, gone blind from glaucoma, because people can go blind from surgical intervention too. And that might also influence your decision about whether to operate.
Still don't take your medication. One eye's blind from glaucoma and not compliant and getting worse. That's
Non-compliance with medical therapy is a big problem. Maybe even a bigger problem is non-compliance with follow-up, quite honestly. That may even be a bigger problem, but that's a double strike. And if somebody falls out of the system and hasn't been taking their medical therapy, you really need to be thinking long and hard about surgical interventions, especially people with more moderate to severe glaucoma, and laser trabeculoplasty for people with earlier stages of disease. And I think even ocular hypertension, there's certainly clinical trial data to suggest that it's a very appropriate treatment for ocular hypertension as well.
Time for one more question. Anybody?
Dr. Anderson.
Yeah, I was going to ask when you emphasized that when you were answering the question of whether or not you would do initial surgery, you emphasized in advanced cases.
Yeah.
Is when you would do that. What is it different in an early case?
That's a great question. I did make mention of clinical trial data to try to guide decisions, recommendations. The TAG trial enrolled patients with advanced glaucoma. Patients in SIGITs that seemed to benefit most from initial surgery were those that had 10 decibel loss in their visual fields at a baseline. So there's abundant evidence, I think, to support in people with more moderate to severe glaucoma. I'm not, this may be my ignorance, but there seems to be less supportive evidence in early stages of glaucoma. Dr. Hodap made a really beautiful point that you ought to consider your treatment recommendations about how many times you can allow them to get worse before it becomes of visual significance. And so maybe you can try things a little bit more in people with early stages of glaucoma. And if it doesn't work, they're not going to get in as big a trouble as people with moderate to severe glaucoma. So how's that being totally not answering your question? Just kind of throw, you don't know the answer, you just throw out facts, and that's exactly what I just did here.
Your comments made me think of another concept, and that is you talk about early and late. That's the static condition that they're in now. How about the rate of progression, if there's evidence about that, so that if somebody's progressing slowly and they're in the moderate range in terms of damage, and they're 96 years old.
Yeah. So this has been brought up a little bit during our discussions, and I have a feeling that Mike's going to bring this up. And my two favorite books are Dr. Hodap's book and Mike and the primer, the Humphrey Visual Field Primer. And I thank you, Mike. I meant to thank you for sending me, a PDF, which I thought, and one of the paradigm shifts I think that you emphasized in perimetry is not focusing as much on whether somebody's getting worse or not, but the rate of progression, right? And so maybe the glaucoma progression analysis, looking at event analysis, whether they got worse or not, certainly has value in clinical trials and all that. But I think the focus has certainly shifted more towards what is the rate of progression, and related as, this idea of cluster testing, doing a bunch of visual fields during the first couple of years after diagnosis, maybe 3 visual fields a year, or whatever the recommendation based on Bal-Chowhan's, more theoretical kind of studies and all, because that's really important. People that are rapid progressors need to be treated more aggressively than people that are getting worse very, very slowly. And absolutely their age needs to be considered, because the ultimate goal here is to keep people seeing and functioning well, having good quality of life through their entire life. And how aggressive you treat somebody that's 80-year-old.
Okay, I think we're ready to take our seats and get started for our 4th session. We have a busy session coming up for our 4th session with 3 different presentations. But before I do introductions and get started, I do just want to speak to my optometric educator colleagues. Welcome you again to the educators meeting. Our last live meeting was in Chicago at ICO. So for those of you who were there, it's great to be back in person with you. Of course, we did 2 virtual years in 2020 and 2021. Murray will have more upcoming details about future meetings. But in the meantime, I'm always trying to keep us in networking and connectivity. This is the resources page at the Optometric Glaucoma Society website, so optometricglaucomasociety.org. We're going to put more resources that we've talked about today already up here. I may be reaching out to one of you educators to help me do all of this, because I got a lot of things. We all have a lot of things going on. But in addition to the resource page, I talked to Danica earlier, and we thought maybe that, those of you who are interested in getting together online, I know that there are a lot of educators here that are new to glaucoma optometric education, and we want to serve as a resource to you. We don't have time at a meeting like this, but we thought we could do that via Teams or Zoom or something like that. And those of us, I won't just maybe name myself, but doing this a long time, we have resources and insights to share how we have been teaching glaucoma, and we can help out many of these new educators. We want to help you, and we want to have a dialogue. And so I think we can handle a quarterly meeting or something like that. If you're interested, share information. talk about our upcoming OGS meeting in San Diego. Again, invite you all, nudge you and encourage you and poke you to join the OGS as a full member, and all those things. So again, I thank my President Eric Schmidt and Murray and everyone else here for holding the meeting, and certainly the Bascom Palmer faculty for providing this venue where we as educators can really focus on not just the clinical information, but how we teach our students and residents. And that has certainly been abundantly clear here that it's a little bit more of a philosophy and approach. The information is certainly important, but the information is always changing. And how we teach our students and how we teach them to think and to be critical thinkers, I think is really important. So with no further ado, Dr. Anderson, I presume, is going to do another video presentation. So I will get started with that, and I'll be back to introduce our next speakers. Thank you.
Well, before I say anything, I'd like to say something.
Okay.
When I was first approached about giving some talks on this Saturday, I was not really fully aware that this is going to be in some way an honor thing for me, that was the intent. I thought I was just being asked to talk.
I concealed it because I knew you objected.
Yeah, and so I'm embarrassed to death, but I appreciate all the kind words that everybody has said, both the people who prepared the symposium and the speakers. Well, I'm embarrassed. Anyway, so now that I've said something, now we can say something. Are you ready?
And embarrass yourself.
Yeah, right. So
There you go.
anytime that you're ready.
It's good to
Wake up.
be with you, and glad to be able to talk to you today about normal tension glaucoma. I have no financial disclosures. The study was initiated because of a 1984 meeting sponsored by the Glaucoma Research Foundation in San Francisco to discuss normal tension glaucoma, which was puzzling to clinicians at the time. Many thought that normal tension glaucoma was not really glaucoma at all, but it was a pseudo glaucoma. It just looked like glaucoma because normal pressure should not be harmful and probably isn't, according to their reasoning. Therefore, lowering of intraocular pressure would be of no benefit in these cases. And what you should do is simply look for the actual cause of the visual field loss or whatever was discovered. Clinical intuition was mixed, however. Some people unable to find a different cause for the cupping and field loss tried treatment, and they didn't find that it worked. It was difficult to lower the pressure from a normal level, for example. And they questioned, does that mean that the intraocular pressure is not involved? Or maybe the pressure wasn't lowered enough by the medications and laser? Surgery, if they chose to undertake that, had some risk of hypotony, for example, and in face of an uncertain benefit, clinicians were hesitant to undertake surgery. However, there were some clinicians who did undertake surgery, aiming to get the pressure down into the low normal range instead of the mid or high normal range, and they said that it did work in stopping the progression of the visual loss. So in a follow-up meeting, it was decided that a study should be done in order to determine whether the intraocular pressure is or is not involved in normal tension glaucoma. And that was assigned to Stephen Drantz and me to design, which we did over a period of several months and discussed back and forth various ways to design it. It was not designed as a intent to treat design. Intent to treat is a design where you say that you're going to start treatment, and no matter what the result was, you followed up and found out whether or not it gave benefit. Whereas we decided that we didn't want to do that. We wanted to compare cases where the treatment had been effective in lowering the intraocular pressure to those that never even made the attempt to lower the pressure. That design was then reviewed with all of the potential collaborators, and the people decided that they did want to become a member of the group or not, and 23 people did sign up. And the first patient was enrolled in 1988. There was a different opinion about what the outcome would be, of course. Some people were more inclined to think that that treatment would work. Others thought, no, it wouldn't work. And everyone agreed, at least they didn't know for sure. They just had an inkling. Only one eye was enrolled, and that was done for ethical reasons, that you didn't assign both eyes of a patient to a treatment that wouldn't work or had side effects. So we had the results, but along the way, before we got to the final result, we learned a few lessons. The first lesson was that 30% lowering of pressure could be achieved without surgery. Now, the only medications that were allowed were pilocarpine and laser. Actually, that's not a medication, is it? But those were the only two treatments allowed. Any medication such as a beta blocker or epinephrine that could conceivably affect blood flow, and it was known, for instance, that there were systemic effects, and of course it affected the optic nerve blood flow from the new drug of the beta blockers that had just come along. But we didn't want to have the effect of the drops on the outcome be a result of vascular effects that were systemic, but we wanted them to only deal with intraocular pressure. So 30 patients were randomized to treatment. 8 were controlled with pilocarpine alone, and 9 more with laser trabeculoplasty in addition. So 17 patients didn't need surgery. And this was something of a surprise, because we thought this was going to be, in the end, a surgical trial where we determined whether surgery was helpful for these cases or not. There were 13 that had fistulizing surgery, but 3 of these had the surgery without even trying the medications or laser. This was the first surprise, and here is the reference for it: intraocular pressure reduction in normal tension glaucoma. The second lesson that we learned before we got to the end result was that visual field testing was non-specific. We did visual fields every 3 months, and the criterion was that if they showed progression compared to a baseline of the average of 3 baseline visual fields, then a second field had to be done. And then if that was negative, they had to have a third field, and they had to have 2 out of the 3 positively different from the baseline in order to consider that they had progressed. And we thought for sure that would be something that would be without false positives. However, by 1990, there were too many endpoints in both arms, such that already more than half, maybe 2/3 of the patients had reached an endpoint of progression within the first year or 2. And it was because we were testing the field so often, and the chance of getting a false positive cumulatively increased so that it happened to most of the patients. We realized that we were never going to find the answer. And we found a method, actually devised a method where we could show how many of the endpoints were actually true endpoints and how many were likely due to chance, because we've been doing the field so often and we just happened to get a field that was different from the baseline. Well, we found that 1 was genuine and 17 were false positive endpoints. but we didn't know which one of the 18 was the one that was genuine. We just could calculate that of the, from the probabilities, we could calculate that one was true and the others were false. So our second new insight was that visual field testing gives frequent false positive progression. And because of this, the endpoint criteria for the normal tension glaucoma study had to be modified. And it was modified such that there was a reconfirmation of progression in 3 months. So the first same series that was done to get tentatively a sign of progression, 3 months later, you would confirm it before you would count it as a true endpoint. Now, we know from other clinical data, meanwhile, it has been shown that when you take fields over and over and over again, you'll get false positives, and that to get a true positive, you had to, if the person had to be truly progressing at a rate of 2 decibels per year in the MD, and there had to have been at least 2 years that elapsed to give enough time for progression to have truly occurred. Otherwise, you're going to think in terms of it being a false progression. And that's clinically useful to know. So that if you repeat fields and you're following a patient, you have to be sure that you've gone at least 2 years and have at least 6 fields before you come to the conclusion of progression. That's the clinical take home for from these studies. Here is the references for this second new insight. Well, we learned then a third lesson, and that was the ultimate result of the study. With the Kaplan-Meier curve, a person showed progression. Here, somebody showed progression at a year, and there's another one before about 2 years, and so on, in the treated group. And after about 7 or 8 years, or maybe 5 or 6 at least, 20% of the people had shown progression, but there were 80% that remained that had not. However, in the control group, there was progression that was much faster, more frequent, and at the end of 5 years, all but 40% had progressed, statistically significant. However, people who looked at the data of the study had another question, and that is, what about the intent to treat analysis, which was usually required from randomized clinical trials, which is to say that if you treat someone and they didn't get much effect from the treatment, you can't just drop them from the analysis. Because what you want to know is whether you intended to treat them and you continued the treatment even though you couldn't tell its effectiveness at the moment, you would still keep data on them. We hadn't done that, so that was difficult to get that analysis. But when we did that kind of analysis, we had to thin the data so it was equal between the two groups that were being compared. We found that the number who were surviving without any field loss was not different statistically. And that was a disappointment. But we realized that some of these people had visual loss that was not really an endpoint in glaucoma, but was due to the fact that cataracts had developed meanwhile. And this happened more often in the treated group because it happened in the people who had surgery, which was, as you remember, about half of the people had surgery and they developed some cataract. And what we had to do was, at the time that cataract developed, when the visual acuity dropped by a certain amount and the clinician confirmed that there was cataract present, we stopped using data from that person. When we did that, then there was a difference between the treatment and controls, and it was statistically significant. Here are the results reported in the two papers, one not correcting for cataracts and the second one after correcting for cataracts. There was still more to be learned, however. We wanted to know what the natural history of glaucoma was without treatment. We had a number of untreated eyes by this time, 49 of people who had been randomized not to be treated, 56 who were still being followed without treatment, because before you could enter the study, you had to show that you were a progressive case and not a stable case. And 56 of the people had never been randomized because they never showed any progression in the first place. 31 were promptly randomized to control because there was a history already of progression when they entered the study. And there were 24 who had a long time of being not treated before they finally progressed and were randomized to no treatment. Here is the natural history, again with a Kaplan-Meier curve, each tick downward representing another case that showed progression. And you can see that over 5 years, or 6 years, or 7 years, why not quite half had shown progression. And so there are many cases of normal tension glaucoma that don't progress. Another way of studying progression is to follow the mean deviation slope. And the slopes are represented by the numbers over here. So from the starting point, there were this number of people in whom the slope was positive, actually. And then a lot more people where the slope was negative. But statistical significance occurred only in ±2, judging from 1 over standard error. Never mind the mathematics. These people here had a false positive slope. And these people here had a potentially false negative slope. The only ones that really count were the ones down here, whose slope was greater, for one thing, and also statistically significant. If it was underneath this dotted line, those cases were statistically significant. So in total, there were a bunch of people that didn't show any progression, although they may have shown technically a progression, it wasn't statistically significant. And there was another bunch that showed progression and it was statistically significant. And the amount of progression varied. Sometimes a half a decibel, sometimes 1 decibel, and sometimes 2 as an outlier over the course of follow-up, whatever they had. The amount of follow-up, the length of time, it's the distance from the origin to the arc or to the point. So this person was followed a short period of time, this person a longer period of time, as was this person. And this person here and that person there were followed for the longest of any of them. So the conclusions from the natural history study was that half of the patients with normal tension glaucoma show recognizable progression in 5 to 7 years. Most of these progress slowly, but importantly, there's a broad spectrum in the rates of deterioration. And remember that in 7 years, only half had progressed at all. What's the explanation for non-progression? Well, some of them may have been congenital anomalies that looked like a glaucomatous disc and had stationary visual field loss. Others may have had self-limited single event in the optic nerve. For example, at the time of major hemorrhage or shock or something, came to the emergency room. The question I ask patients is, have you ever been so sick that they thought you were going to die, but you recovered anyway? And that's time when the nerve may have been damaged. Now it's not getting more and more damage because the event that occurred is over with and they've been cured of that. There have been cases that have certainly been documented like that. And some may simply be progressing too slowly to be recognized as progressive over a course of 7 years. And of course, there are ones that clinically you might have less concern about. Here's the reference for the natural history of normal tension glaucoma. Clinically, it would be helpful to predict what it is that determines whether progression is going to occur in a particular individual and whether it will be fast or slow. For that reason, we undertook an analysis to recognize risk factors. And that takes us to the 5th lesson that came from this study. Well, now for lesson number 5 from these data. What are the risk factors for progression if you didn't treat them? The risk factors that influence the rate of disease may not be the same as the risk factors for having the disease in the first place. Factors affecting the likelihood of having normal tension glaucoma come from prevalence data. Factors affecting the progression rate is discerned from progression data. And that's very different. For example, here we have progression with and without disc hemorrhages. People who have no hemorrhages progress less often and more slowly. And those that do have disc hemorrhages, especially repeatedly, are more likely to show progression in the course of time. That's just an example. And the factors that we uncovered were these. Racial heritage made a difference. And in particular, at the two extremes, Asians tend to progress slowly, whereas Caucasians more rapidly. Gender, females progress faster than males, especially if they had migraine. And thirdly, as we've already seen, disc hemorrhages increase the rate, especially if the hemorrhages were frequent. We found that all of these things we did not find affected the rate of progression at all. Now, many of these, the number of patients in the group was too small. And so they don't really count as showing that it did not affect it. But the ones with the asterisks, such as blood pressure, diabetes, family history of stroke, and so on, did show a relationship to how fast the field loss would occur. But most of the subgroups that we looked at simply had not enough subjects to make a conclusion. Risk factors for the prevalence help you clinically in knowing which patients to look to see whether they have normal tension glaucoma after you've already determined that they don't have a particularly bad intraocular pressure. Factors that affect progression help you decide the expected prognosis without treatment or with inadequate treatment. And so it affects how often you follow up the patient and also affects the how aggressive your treatment is. With no other information, a new case of normal tension glaucoma has a 50% chance of being progressive in the course of 5 to 7 years. You could delay aggressive treatment just as you might for ocular hypertension, unless normal tension glaucoma damage is advanced maybe already threatening fixation. You don't want to take a chance that there'll be even a little bit of progression. You will also be aggressive in the case, for example, of a female with migraine and disc hemorrhages. That would certainly point to a higher risk, and then more aggressive treatment would be indicated. So clinically, the factors that affect progression are not the same as ones that affect the risk of having normal tension glaucoma in the first place. Understanding the traits that are linked to progression may guide your management, how aggressive it is. Moreover, understanding the traits that lead to progression, especially if it's fast, can also help identify pathogenic factors, so that you say, for instance, migraine or vascular dysregulation is something that will make for fast progress. It helps you understand, perhaps in detail, what the pathogenic factors are, that is really something to do with vascular supply or with the regulation of blood flow or something like that. And it points the way to something that might be useful therapeutically. So it's good to keep in mind the things that we know about that and discover more about what affects the rate of progression. Here are the references to risk factors for progression. Oh, one more lesson. Lesson number 6. What is the benefit of lowering the intraocular pressure? Well, it turns out there's greater benefit if you're female, especially if you have migraine, greater benefit if there's a family history of glaucoma, and greater benefit if there's milder disease that's going to end up progressing faster. There's less benefit if you have disc hemorrhages at the baseline or along the way. There's less benefit if there's a family history of stroke, that is arterial occlusive disease, or if you have personal history, the patient himself has cardiovascular disease, heart attack, stroke, and so on. So we now have an analysis of 3 classes of traits. Traits that make a person more likely to have glaucoma in the first place. Traits that affect the rate in which progression occurs. And traits that relate to how much benefit you get from lowering the intraocular pressure. We can also talk about what we might learn or suspect from about the pathogenesis. Glaucoma with vascular occlusive disease, or more correctly, in patients with vascular occlusive disease or in their family, may behave differently from those that have vascular dysregulation, which used to be called vasospasm, and has Raynaud's phenomenon, migraines, a number of different things that you need to learn about, but you can't go over them right now. Intraocular pressure is more relevant with dysregulation and less relevant with arteriosclerosis, both for detecting the disease and for applying treatment. Here's a reference to this study. And to summarize everything that we've learned here, one is that a 30% lowering of pressure can be achieved with medications and laser alone in 30%. Secondly, that visual field criteria for progression are not very specific. Especially if you repeat the test, you're going to get some false positives. Thirdly, we've shown that in normal tension glaucoma, intraocular pressure is involved. That was what we set out to prove in undertaking the study in the first place, is whether intraocular pressure was involved in these cases. And we found that lowering intraocular pressure helps. The manner of lowering intraocular pressure matters in that surgery is more likely to cause either hypotony or cataracts or other complications. And so if medical treatment and laser will work, Great. Normal tension glaucoma has a variable rate of progression, so you need to monitor carefully and determine whether this is a person with a rapid rate or slow rate. There are traits that will represent underlying pathogenic factors that affect the natural course. Some of these traits are more affected by the level of intraocular pressure than others, and therefore have different degrees of pressure lowering that will benefit the patient. Some factors are genetic, some are gender related, and some are circulatory, either obstructive or vasospastic. Some of the pathophysiology might be affected by the level of intraocular pressure more than others, and that is the different cases will have different degree of benefit from lowering intraocular pressure. Noteworthy is that there are particularly two different kinds of vascular disease. One is microvascular disease, which is called these days vascular dysregulation. Used to be called vasospasm, represented by migraine, Raynaud's phenomenon, and various other signs that you can ask a patient about and recognize whether they have this tendency of microvascular disease or not. The other type, however, is obstructive arterial disease. They behave differently with regard to the intraocular pressure and have a different degree of favorable response to treatment by lowering the intraocular pressure. One more lesson. There are indeed two populations of patients with glaucoma. Schulzer, the biostatistician in this study, and Drance, the co-principal investigator, had shown long before this study that there were two different populations with chronic open-angle glaucoma. And their course of disease, the severity of the disease, and response to treatment and so on, all were different depending on whether they had obstructive arterial disease or vascular dysregulation, which fits very nicely with the findings of the normal tension glaucoma study. Well, I thank you for your attention. Well, good morning. It's good to be with you and glad to be able to talk to you today about normal tension.
Questions?
The normal tension glaucoma study predates the clinical application of corneal hysteresis in glaucoma assessment. So I'm curious what weight you put on corneal hysteresis in determining risk of progression in glaucoma in general, and then normal tension patients specifically.
I don't think corneal hysteresis was really even studied at the time, 1988. Did I mention that at all?
No.
No, just any perception on its influence now, or, I mean.
Well, all measurements of intraocular pressure, and I guess corneal hysteresis isn't quite the same. It's a something on which pressure measurement is based, but and I've never been a fan of thinking that that had anything to do with what was going to happen to the person. But it certainly was not in this study.
Right. One other risk factor that I don't think was mentioned, so I don't want to go too far on the same tangent, is sleep apnea.
Yes.
And that has had an on and off again. Is it a risk factor associated in back and forth evidence? Any clinical pearls on where that's?
Yeah, so sleep apnea and what they call dippers, people whose blood pressure goes down at night and get to very low levels, have all been associated to some degree with progression in glaucoma. You have to be very careful about that. For instance, with the dippers, if the blood pressure, that's the arterial pressure, goes down, on what physiologic basis might it go down? Well, it might go down if you had vasodilation in the capillaries. So there's less resistance in the capillary bed and the arterial pressure will be higher. But the amount of blood that goes through the capillaries is really dependent on the cardiac output. And the cardiac output is distributed among the capillaries in the body according to how much resistance there is in each vascular bed. So it doesn't seem logical that it would be clearly a predictive thing. And sleep apnea, I think, is in the same category of having a transient ischemia. I guess it could have some effect, but I'm not sure how clean that data are.
I think somebody named Dave Greenfield looked at dippers. What did he find?
So we looked at both. We looked at the sleep apnea group as well as dippers separately in 2 different studies. The sleep apnea has been known in controversial studies, some that it is a risk factor, some that it is not for the development. And we looked at sleep apnea only in eyes with progressing open-angle glaucoma over a 5-year period of time. And they all had sleep studies done here in Miami. And in these group of progressing eyes, there was no relationship between the speed of progression and the severity of any of their sleep apnea parameters. Not a huge study. These are hard studies to do. And in the blood pressure, we actually did find a relationship in our study, in the Logit's trial, where blood pressure medication was associated with the development of disc hemorrhages and progression. And we are now looking prospectively with a 24-hour ambulatory blood pressure monitor in eyes that are really carefully monitored every 4 months, not every 3 months like this study, to see and analyze that data. So we don't have that data, but that is a very well-studied group with the 24-hour blood pressure data.
But you don't have an answer.
We do not have an answer yet. Stay tuned.
Yeah. But as I said, a low blood pressure doesn't mean a low nutritional blood flow rate.
Right.
Right. Danica?
It seems that many of us have a few normal tension glaucoma patients that seem to progress no matter what we do. And you can get their pressure really low and they seem to continue. Do you have pearls or ideas about what we should be doing for those patients? Is it really glaucoma? Is there something that we're missing? And how can we approach those patients?
Well, it's obvious that, of course, intraocular pressure is the main thing that we focus on all the time. If a patient or a friend asks you, what is glaucoma exactly? The first thing out of your mouth is, well, it's a pressure in the eye that, and then you explain that. We're focused on that. And the progression part without so much pressure that you are puzzled by this, I don't know how you explain that. There are some people that just seem to progress all the time. Now, sometimes these are people where the pressure is 13 and 14, 12, 15. And David Greenfield taught me that, well, what you need is a single digit pressure. And you need to have a really experienced and good surgeon to do that and achieve that without getting hypotony or some other complications. But that seemed to work in at least the one patient that he and I shared, in which he did the surgery and he was able to successfully get the pressure in the single digit range. And that patient, well, I haven't heard in the last year or two. Is she still doing well?
I haven't seen her in 12 months.
You think she's still alive? She was quite old. You don't know.
And if you report back to you. So there was a study done by Eric Greva and Carolyn Heisen in Holland, where they had people who were progressing with normal tension glaucoma, or at least progressing at low pressures on medication, and they looked at the rate, and then they operated on them, and the pressure was down around 10 or 11 or something of that sort. It was already pretty close to that. And the number of people who progressed and their rate was cut in half. And Hemo Susanna in Sao Paulo has brought up something. He does something called a water drinking test. And I don't do it on everybody, but there is one situation where I find it useful. You have somebody in every clinic time, they come in, the pressure is 13, 12, they're on 3 secretory suppressants. And you say, do you drink much water? They go, oh yeah, it's really good for health. I drink 6 liters a day. And I say, okay, well, listen, bring a bottle. If you drink a liter at a time, let's take your pressure 30, 40 minutes later. They're doing this 6 times a day. And the pressure goes to 25 or 30. And the point is, if you have really poor outflow, you can, with an unusual osmotic stimulus, get to much higher pressures. And then when sitting in your clinic for an hour or 2 before you see it, they're all dried up. I mean, it's not necessarily happening there. So I do ask patients who are progressing with low pressures where I'm curious about it. Yeah, just tell me about how how much fluid you take a day or something. And it's just surprising to me. I guess I haven't got a control group of people who are doing fine, but how many of them drink extraordinary quantities of fluid in a day and think it's something very healthy for them? And as I say, I don't do it as a predictive test, but I do think it's useful to ask them about it. And if it's unusual, to test it in that person and show them the result. I think those are the people probably who, when you do an operation and the fluid isn't going to make the pressure go up as much because fluid's going out through a filtering operation, would not have that problem anymore. And that may be important in the day where we're using so many aqueous suppressants.
What you say is very sensible, but I guess we can't come to a conclusion about it without.
I've seen several people who were getting worse at 13, 12, and I operated on them, and at 9, they didn't.
How about if you had them stop drinking 6 liters of water per day? Did that help them? Did it stop the progression?
I haven't seen them long enough to know, but I did say, listen, let's either have you just take no more than a glass an hour, drink all you want, but no more than a glass an hour so your kidneys can keep up, or we could do an operation. And one guy said, well, I'm not going to cut down on the amount of fluid operated on me. So we operated and he didn't get worse. So what can I tell you?
Well, it's great to see that at 4 p.m. in the afternoon, we're still having dialogue and debate, as energized as we were this morning. And I am pleased to introduce Dr. Paul Palmberg, professor of ophthalmology here at Bascom Palmer, who will be our next speaker here. Dr. Palmberg received his MD and PhD at Northwestern University, FIME in Chicago, clinical fellowship in research also at WashU, and he's going to be talking about the clinical trials in glaucoma. Dr. Palmberg, thank you.
And I'm in my 42nd year of a remedial fellowship with Dr. Anderson, as he does remind me from time to time. Here comes the PowerPoint. I was asked to talk about what changes in my practice I've made from the clinical trials. I want to say this carefully. Not much, because they all showed I was right. And it's not fair because I was inside of them watching the results too. But anyway, so I'm not sure why we're not just showing the first. Do I have to do something? No. Okay. So how have they changed my practice? You have joined this meeting while logged into.
Dr. Palmberg, just give me one moment. I could fix this for you. I need control of the mouse still. Thank you.
Okay. We will control the horizontal. We will control the vertical. Okay. So if when I advance, I'll just use this. Okay. Push this.
Okay, you could just go ahead and click once on the screen and then move forward.
On the screen. Okay. On that one. Yes. Okay. And this includes also one study, which I call Consequences of Surgical Intervention Miami, which was my study of using anti-metabolites in filtering surgery. So, this week we lost Queen Elizabeth. I happened to be in London with my daughter Elizabeth when she graduated from high school, and we were celebrating her getting into Stanford and getting 1,600 on the SAT. And at any rate, we got enough money from that to pay for this trip. And here came a royal procession where we're standing outside of Westminster Abbey, and there's the Queen, and she's looking right at me from like 15 feet away.
And at that time, I looked very much like President Bush, the first president. Read my lips. At the convention, I meant to say, no new Texans. Came out, no new taxes. People cheered. Wasn't gonna tell them it was a mistake. Not gonna do it. Wouldn't be prudent. Anyway, well, here she's, had a wonderful 70-year reign, and then also in this procession were Princess Diana and now King Charles III, just, about as far away as you are. I mean, going right by us when I happened to take the pictures fast enough. Anyway, but it was wonderful to see them. And this reminds me that we have Doug Anderson here for 53 years on our faculty, and he's still reigning. And for those people who say, see you and they say, gee, you really haven't changed. Yeah, we have. This is probably from about 35 years ago. And of course, we have Rich Parrish and Elizabeth Hodap and Alana Gradusky and several of our fellows who are well-known people. And we really have all taken from Doug all the things that were said about him good before. His humility, scientific rigor, and the patient coming first. And of course, Dr. Norton, our founder, did that too. And I guess it shows, since the place has been #1 for a long time, that these kinds of values of caring for people actually work. So these are disclosures. None of these are relevant to what we're talking about here. But what is my experience with clinical trials and practice patterns? So I was a mass clinical evaluator in the 5FU trial. I was sure after some initial experience that it worked. So I could not be an investigator. You really don't want to get into a clinical trial where you know the result. You're just going to be so tempted. And I made sure that people who needed a complex filtering procedure all went to the trial and were not referred to me, because I would not have been able to take a one-eyed person and say, I'm going to send you off to maybe not get this, when I knew it worked. And of course, it turned out I was right about it based on our experience, but it did need to be proved. And if you get involved in a clinical trial, that's always a potential problem. Al Summer, who is one of my heroes, was asked by the American Academy to set up the first preferred practice pattern of the American Academy of Ophthalmology, and they chose glaucoma. And he chose me to write a chapter on the rationale and effectiveness of glaucoma therapy, in which I included a lot of practical information from Chandler and Grant. And by the way, Dr. Chandler, of course, was Doug's teacher in his fellowship. And I introduced this term, target pressure. And what did we know about it at the time? And I'll show you a little background for that. And then I was on the monitoring committee of Aegis and Sigis, and I was the only person on the monitoring committee of both of them. And I used to tell people, I can't tell you anything about the trial, but don't bet against me, because I wasn't seeing the results coming in. And I was going to be an investigator in Aegis, but they said, you can't use 5-fluorouracil. It was 1988. And I said, but I've been using it since May 11th of 1982. It was suggested by Blumenkrantz and Rich Parrish had done on monkeys. And it worked. And I said, look, I've looked at my patients. I'm following up on my patients, see how they do. And in Miami, a third of my surgery, my TRAVs, are failing by 18 months if I didn't use this. And when I'm using it, I'm getting like 90+% working. And the average pressures are down around 11 instead of 11 or 12. They're not up around 15, 16. And I don't want to ever do a TRAV again without an anti-metabolite. I said, well, you can't be in the study. But why don't you be on the monitoring committee? And I thought to myself, I'm going to operate on people in Miami. I'm going to keep track of the results. They look very much like the people getting into this study, and I'll be able to compare their results to mine as time goes on. Of course, it's not randomized, but it's darn good control. And so I'll show you about that. And then I was asked to write the editorials when Oates and EMGT came out. And I guess if you're asked to write the editorial, it means you're practically the only person in the country who wasn't involved in this study. And then have written some about what is it that matters about pressure? Is it the mean? Is it the variation and that sort of thing? And in fact, I'm supposed to write one this weekend for on the same subject again for one of the journals. Well, how have they changed my practice over time? Well, the results of trials could either change your practice or confirm and refine it. And I guess I will say I went out and bought a pachymeter after Oates came out. That was probably about the only change. But my initial understanding of how to manage glaucoma was based on my experience in residency, but especially in my fellowship at Washington University with Bernard Becker and Michael Cass, because I learned a lot of things from them to do and to not do. It sounds a little funny. So what is a fellow to do? You know, you were asking the question early, how can you get experience in a short period of time? Well, I realized that if I was going to get a real long-term perspective on a chronic, usually slowly progressing disease, what would I have to do? I would have to learn from the past. As it happened, as was already mentioned, I think that there were wonderful visual fields that, well, they were done here, but they were also done in St. Louis. Wonderful visual fields. And on Sunday afternoon after church, when I wasn't busy, I would go in and read the charts of the patients for Monday for Dr. Becker that had 10 to 20 years of wonderful visual fields to see what happens to people over time. When I had time to meditate and think about it and see long-term outcomes. Actually, it was a pretty smart thing to do, I think, but at any rate. And what I saw is that at high teen pressures, most of the patients, now I'm talking about people with advanced disease who tend to get referred to big centers and, they're in a lot of trouble. Most of the patients with advanced glaucoma progress substantially, and Hart and Becker subsequently, I think, showed that something like 80% of such patients advanced in a decade, and that 50% lost half the remaining field. I hope I've got those numbers right. I added it last night, and I didn't look up the paper yet, but I think that's substantially correct. That people with advanced disease, and they were running pressures of about 17 to 18 on the pilocarpine, epinephrine, the few things that were available at the time. On the other hand, people who had once had a high pressure and were at low normal pressures, 11, 12, 13, usually because they had filtering surgery that just happened to work really well, they were stable for a decade. It was really startling. I don't think more than 8% of them were noticeably worse after a decade if their pressure was about 13 or less. And this went against the prevailing view, even of my teacher, Dr. Becker, that high teens was the goal. After that, after all, once you get to normal pressures, why would it make any difference? And there were people like Ron Bird, and there were people like Brubaker who said, if you're getting worse at a pressure of 17 or 18, it's nerve rot or it's chronic ischemic optic neuropathy. There's nothing you can do about it. And if you operate on them, it's dangerous. You're going to give them a cataract, you're going to get infections, you're going to have problems, and it can't possibly benefit anybody. Because after all, it's a normal pressure, just as Doug brought up. And that one could only slow the damage in glaucoma. But I saw the results of 10 to 20-year follow-ups of people who were stable, whose pressures were that low. And I decided, if I see such patients, I'm going to try to get them there with medicine or surgery. And so I was thought of as being somewhat aggressive for those people, but I thought it was on a good historical basis. Well, I found out as I kept reading more that Paul Chandler had beaten me to it by 17 years. And this is Paul Chandler, who was, as I say, Doug's teacher and was at the Mass Eye and Ear Infirmary, and of course, Morton Grant, who worked with him, two icons in our field. And the best thing to read is Chandler's survey article, where he puts all his thoughts together, which was published in 1977. So here's basically what he said, and I call it Back to the Future. because after we spent $100 million and had 6 clinical trials, we found out that basically the guy was right. He said eyes with advanced damage, and by that he meant at both poles of the disc. So I don't know if he ever talked to you about vertical oval cupping, but he mentioned at both poles of the disc that those people he found in his clinical experience required a pressure below the average normal to do well. And that otherwise his clinical experience was that far too many of those people got worse. Not everybody, of course, but that the risk benefit in his hands was much better in people with, let's say, damage at both poles of the disc, or maybe we'll say minus 10 decibels of mean deviation, for example, much better off if their pressure was 15 or less all the time. And he said if eyes have limited cupping that is confined to one pole of the disc, they stood pressure better. Maybe they would tolerate 15 to 17 or 18, as long as they were brought down, 20 or 30% from where they had been. He also said, quite startling for 1959, the appearance, he said, if you have a normal disc and field, they can withstand pressure well over many years. So he understood the concept of ocular hypertension in 1959, that you do not need to be aggressive up to a pressure maybe even 30. And that was very remarkable. And as you say, Armley took a lot of guff for it. I don't know if Chandler did. But he said that the appearance of the disc serves as an important guide to the management of glaucoma. And it's true. So what are the randomized trials? What have they done for us? They've shown us the natural history of untreated glaucoma. And Doug has talked about normal tension glaucoma in that regard. The outcomes of various treatments, treatment compared to nothing, different treatments compared to each other. They have shown us how much of glaucoma damage is pressure dependent and thus avoidable. And they've shown us how to stratify cases by the degree of presenting damage, intraocular pressure, and age. And so the whole target pressure concept, my concept of it was initially, at what pressure are people not likely to have pressure dependent damage? And I based it on some of Chandler's studies and by a comparison of surgical studies that George Spaeth and Al Coker and other people had done, and Tor Odberg's observation, long-term observations on his glaucoma patients that showed advanced patients needed to be under 15. People with milder damage did pretty well if you got them down about 30%, got them in the mid to upper normal range. And that was the basis of the target pressure concept. Now, the Academy changed it to balancing risk and benefit in thinking about it. I was thinking only in terms probabilistically of the science of the relationship between pressure and damage, not necessarily what you should do, because obviously somebody dying of cancer next week didn't need to have something aggressively done. You have to put it in some context. Now, I'm going to ask a question and this is an important thing in teaching, how much of glaucoma damage is associated with an excess pressure distribution? And Doug showed you earlier this study in Ferndale by Hollows and Graham, where they looked at 4,000 eyes. And they found a distribution with a mean pressure of 15 and a standard deviation of 3. So that's where the 9 to 21 comes up with. And then the people with glaucoma with an average pressure of 23. What we probably missed in 1966 was there was only one patient with pressure in the bottom half of the normal distribution. Sure, a third of the people had glaucoma in the upper normal range, but only one here. Would it help to take these people from there to here? Then there's Baltimore Eye Survey. This looked at white and black patients, the prevalence of glaucoma out in the population of Baltimore. And I reviewed this for the study section for the for the National Eye Institute. And I really pushed this. This is the only study I need this time, but I have to have it. The budget's $2 million. It has to be done. These are the right people to do it. And I want to add to the budget. I want to add an automated perimeter so they can have data that they can deal with better. And people went berserk, but they agreed to do it. And so that's why the study had an automated perimeter. Anyway, and then there was, if you did a receiver operating characteristic curve on this, which I'm not showing you, you would say that only 1/3 of glaucoma was accounted for by the difference in pressure distributions in this population. Only a third. Now go to Japan, a Chijimi study, where the average pressure in the population is also 15. But the average pressure of an open angle glaucoma patient is 15.6. And 90% of their glaucoma is normal tension glaucoma. Same thing in Korea, 90%. In the LALA study in Los Angeles, it's 80% of the people who are really Asian, indigenous Mexicans who they looked at had normal tension glaucoma by the idea of being under 21. So it does differ tremendously by racial groups. Here you see in Baltimore, 3 to 5 times as many cases of glaucoma at every pressure in this population, and in Japan. But we somehow have not found the genes to account for all that. Well, anyway, how promising is it to lower pressure if it's only 1/3 or 1/10 of the problem? Well, the surprising answer is nearly all glaucoma can be reduced of high pressure patients, and apparently 2/3 in normal tension glaucoma can be halted or slowed down by getting the pressure down. Now, why in the world would that be? And the reason, which Doug has explained to me, and I think I agree with it, is that either getting pressures near the episcleral venous pressure might compensate by improving blood flow, but it's not going to help you to get below the episcleral venous or the orbital venous pressure of maybe, 9 to 11 or something. It's not going to help you get 6. You're not going to improve blood flow by getting lower, but you really would like to get in that range of 8 to 12 to be optimal. I'm not saying everybody needs that. I'm just saying theoretically that would be optimal for blood flow. And hey, if it's a pressure gradient across the optic nerve head, it's the same thing. The cerebral spinal fluid pressure and the venous pressure are pretty much the same. So getting below that wouldn't change the pressure gradient across the optic nerve either. So that made me want to get people to something like 8 to 12 if I could, if they were progressing or they had a lot of damage and their pressure was 26 and on everything. So this is not at all like diabetes. I did a study in St. Louis on that led to the diabetes control and complications trial. I looked at 450 juvenile onset diabetics, took stereo photographs, read the 40,000 photographs, was on the monitoring committee of the study. And I asked, what's the relationship between hemoglobin A1C on the people who stayed on usual control or went on tight control and went from 9.2, stayed at 9.2 versus going down to 7.2 with intensive control? And it turned out you could cut out the bad things happening to the eye by 75%, could be reduced. But I said, there's an overlap between the people you treat intensively and not. Look at hemoglobin A1C versus what happens. And it turns out a 43% reduction in risk of progression for every point lower hemoglobin A1C from 10 to 9, 9 to 8, 8 to 7. We don't have enough people to know where the J in the curve comes. Well, after that experience, I was involved in the studies in glaucoma, and I brought the same idea. Oh, by the way, there was also 33% more chance of a hypoglycemic episode requiring medical attention. Risk benefit to think about. Well, but in glaucoma, it's not like blood sugar. We're getting to normal blood sugars should really be is very beneficial. Or hypertension, where getting to upper normal pressures really does give you nearly all the benefit. And the advent of anti-metabolite filtering surgery here, because of Rich Parrish and Blumenkrantz suggesting it to him to use 5-FU, let me try to get this. And so starting in May 11th, 1982, I began using it in all my glaucoma operations. And that was the first case. So I got to do the first case, but it was only because of Rich Parrish and others. But we started to see blebs like the 6th filter in a young black guy work. And turned out we were lucky in those first cases, because it turned out it only made the 5-year success 50% versus 20 in people having a second operation. But I started doing primary cases in May of 1982. And I used a valve-like incision that has flow at about 4 to 6 millimeters of mercury. I carefully checked that in the operating room. And then I put stitches in it and I adjust their tension to 8 to 12. And I used the tone pen at first, and then I learned how to push on the cornea with a 30 cannula to estimate it. And then I used a big dose of mitomycin. And my thought was, if I can set the pressure right where I want it with the scleral resistance, and then prevent the formation of resistance outside the eye, then maybe I can keep people where we want to have them. And in fact, it turned out that I went the wrong way. I did have the pressure the next day average 10, and at a week and a month and a year. Now, not everybody kept working. The success rate, however, at 5 years was 85% versus the tube versus trab trial that used the primary tube versus trab, which had a 3 times higher failure rate by the same criterion using a shorter application of mitomycin. So one has to apply it with thin sponges, and I'm not trying to teach you how to do surgery, please, but it does mean that using a longer dose gives you a longer lifespan of success, out to 10 years, still having 60% of the people at 15 or less, and they started at 26. Well, what was the result of the fields? And I keep everybody in the study, if they fail, I do something else. So nobody drops out. The pressure is 26, came down to 11. What happened out here? We had really good data to 7.5 years. And what happened to their visual fields? No net visual field loss in an entire group of people. And I would go to Arvo and show this, and I would hear people behind me, he's dangerous. He's using the 5FU and later mitomycin on primary cases. He's dangerous, but these are advanced patients, really. And everybody knows that glaucoma patients get worse. You can only slow it down. You can't stop it. So he's crazy. He's lying. And I'm hearing this behind me. He's an evangelical Christian guy, and he thinks he's got magic hands or something. I don't know. Jesus, heal him, But no, it was science, and people wouldn't listen for a long time. And the mean deviation was actually just slightly improved if you take the field versus the first field for everybody. So I had the stuff showing you could stop glaucoma, and I couldn't get the Aegis people to publish their results showing that if you got the pressures down to this kind of level that you could stop it. They just said, no, that's not what the trial is set up to do. We did see some people progress, but some seemed to get worse on multiple testing, and some seemed to be getting better, kind of equal numbers. And I thought, okay, well, that's noise. You keep testing, you're going to see this. But Kyoko Ishida, who was working with me, my brightest fellow ever, said, and for Japanese to tell you you're wrong, that's hard to do. And she said, no, the maximum pressure makes a difference. The means were the same of the people who progressed versus not, having 2 consecutive fields worse by 3 decibels of mean deviation. But the maximum pressure was different. Now, before you start thinking, oh, the peak is more important or the variability or the mean, remember that studies like EMGT found the mean mattered if you don't change the therapy. If you use Batoptic and laser trabeculoplasty, never change anything unless they get worse or they're really high pressures. They saw the mean matter and others not. If you do a surgery study and some of the people start to fail and their pressures are higher again and their field gets worse, it's going to look like the variability mattered. So what it really means is consistently low works, and not being consistently low, not so much. And so I don't know that variability really can be looked at if you're constantly changing the treatment if people get worse. We did see nobody get worse in many years. It was only 15 who always had a pressure of 13 or less. We found 21% had gotten worse, 2 consecutive fields, if they ever had a pressure of 14 to 21. And there were a few people, 38%, who of the ones who got to a pressure over 21, in other words, they failed, who had gotten worse, even though we jumped on it. We saw the patients annually and they were seeing their own doctor in between. 38% had gotten worse just within a year, or potentially when their pressure had gone higher. If somebody's pressure was 13 or less at all visits, they had improved. They had recovered 2 decibels of mean deviation. Intermediate group about 1. The others were stable at first and then started getting worse. So there really were some people getting better, some people getting worse. And the idea of visual field recovery was kind of new to me. I hadn't really seen that until we looked for it, until Kyoko pointed it out to me. Now, so I'm on Aegis and they come out and they say, hey, we found, even though the trial says we're going to compare laser to surgery, they said, we're changing the endpoint of the trial. I said, what? You won't publish that getting under, they looked at it for me and said, if you're under 15 all the time, it's a flat line. I said, my God, you've got to publish that. And they said, no, we can't publish that. That's data derived. And I had data showing you could do it. And they would not publish it. It was driving me crazy because you had useful information that was not getting out. And then they found a race interaction. They found out that in Black patients, if you did laser or surgery, 26, 27%, in other words, the same, got worse by 4 Aegis units twice, which is 5 decibels of mean deviation. And in white people, only 20% got worse if they had surgery and 34% if they had laser, because laser is not as effective in whites as blacks, and surgery is more effective in whites than blacks. So the National Eye Institute says, skip laser in white people. And I went berserk. And I said, this is horrible information. This is a horrible advice you're giving to people. It's terrible. Think about it. And I managed to change what the National Eye Institute said. I said, look, do that analysis of who gets worse by pressure, no matter what their treatment was. And if you see that getting down to a certain level keeps people from getting worse, but you might be able to do it with laser first, isn't that still the best thing to do? And then if you don't get it down where you think you need to be, then you would operate? They said, oh, that might be better. Okay, we'll publish it, but we won't publish under 15. We'll publish under 18, even though there's hardly anybody in that group who's between 15 and 18. We'll publish that because the protocol did call for getting under 18 in these advanced patients who had 10 decibel loss. So here are the 1/4 of patients, 105 people, followed for 6 to 8 years at a mean pressure of 12.3, no net loss of visual field, which matched what I had been saying. And I was so happy when that got out because people said, okay, he wasn't crazy, he wasn't lying, he's still dangerous. But anyway, okay. And as it happened, then Eric Grava came to me in 2001. He says, you've won the World Glaucoma Prize. And I thought, that's for the best paper the previous year. I didn't publish anything, but he knows who I am. I said, for what? And he said, well, for this study showing you can stop glaucoma from getting worse in the large majority of people. And I said, oh. And I thought, I got screwed on the DCCT. They never gave me any credit for the stuff, my natural history study. I got screwed on corneal preservation media. I put the color indicator in and Heppy's buffer, and I never got credit for that. But it wouldn't be right for me to get all the credit for this. And I said, well, listen, why don't you go back to the committee and tell them, why don't you say, this is Doug Gasterlin's life work. Why don't you tell him that he and the investigators want and ask if I can share it? And that's what happened. So they didn't hate me. And when Doug Gasterlin got invited to go all over the world and talk about this result, he said, well, I don't really like to travel or talk, but Pomberg is our PR guy. Invite him. So I got to go to 6 continents in 5 months to give people good news. And while I was at it, I could tell them, apply your mitomycin the way Peng Kaw did. Okay, so there it is. Now, the chances of getting worse, it's a graded thing. At this point, you're losing about 2.5 or 3 decibels on average after 8 years if your pressure is around 15. I would rather be down here if you're doing surgery anyway. And I had a way of avoiding hypotony with the valve. And Peng Kaw found a way of making it much safer for bleb problems, got it down to 1% problems with his way of applying it. So if you need surgery, I think it can be done a lot more safely than it was done at first. Here's the EMGT, where the natural history, much worse in pseudoexfoliation than POAG than in primary open angle glaucoma. And very much like Doug's study, half the people got worse and half didn't without treatment. But the ones who got worse, certainly in pseudoexfoliation, it was way too fast to watch people to see if they're getting worse. And I would contend, I really wouldn't want to watch anybody with real glaucoma get worse without at least mild treatment. Their treatment effect with Baytoptic and laser trabeculoplasty in Swedish patients did lower the pressure on average 25%, but there was no goal. If it didn't lower it at all, they just left you there. And so there's no target. And they did find a dose response relationship with the pressure. For every millimeter of mercury, there was something like a 13% greater risk of getting worse. But this is a lousy treatment effect. From 62 to 45, I'm sorry. I'm glad it worked, but hey, I can help you a third of the time to be better. So that didn't impress me too much. I was surprised that the medicine group at 17, in people with about -5 decibel loss to begin with, had done as well as the surgery group at 14. But if you had 10 decibel loss or more, the surgery group did do better. But it did show that it was adequate to get to Paul Chandler's, mid to upper teens in the mild initial case. It was okay. Why can't I get that to go? Oh, here. Okay. But it did require, unlike EMGT, a target pressure of 30% reduction. And I would recommend that not only for normal tension glaucoma, I would recommend it for any glaucoma patient you're treating. Try to get them down 30%, at least adding simple things. And if they're advanced, you really need to get down that much. And in this study, if you had advanced damage, you might have to get down 50%. It was a sliding scale, very aggressive sliding scale of target pressures, which turned out to be very effective. But in that study, there were, and it was much better than what happened in Sweden, much, much better. You had no net progression in either group in the first 7 years of the mean deviation. It stayed 5 decibels. However, I was on the monitoring committee and I said to myself, wait a minute, they're telling me 20% of the people are getting worse in both groups and the mean's not changing? What's going on here? And so again, what I was good at is asking questions. I asked Aegis, what's the best we can do? And I asked these folks, what's going on with people getting better and worse? And they looked at it when I asked, and it turned out there were an equal number of people getting better as getting worse on 2 consecutive fields. And I thought it was noise, but again, Kyoko Ishida's idea, we applied to this and found out it was right. It's not all noise. Some of it certainly is noise, but not all of it. Because if it's noise, there should be no correlation with intraocular pressure or other features, but it did. It correlated with the pressure, as I'll show you. It correlated with gender. Women were 60% more likely to recover 3 decibels of field compared to their 2 baseline fields than men. And if somebody had had cardiovascular disease in the past, but no stroke or heart attack now, you could stabilize them, but they didn't get better anywhere near as much. So it goes along very much with what Doug was saying earlier. If you got bad pipes, you got bad pipes. If you have vasospasm, you might be able to help by lowering the pressure. Well, we found this percentage of visits. They have 10 visits in the first 5 years. This is percentage of visits better by 3 decibels. And you see a dose response curve. And my question was, well, but how much of that's real and how much of it's noise? And so the answer is I came up with the idea, let's subtract the percent of visits that look worse in these eyes. And we already knew from some baseline testing in the study that 6% of the eyes would have a false positive benefit or worse. And the difference should be real. And it turned out here you have a dose response curve between the percentage better and the percentage worse. But it's only like 1 in 8 people or 1 in 8 fields that have gotten better. Now, we can't tell you which individual got better, but by using large numbers of people, you're able to answer questions, even though you don't know. It's a little bit Heisenberg uncertainty principle. You don't know which one it was, but you do know that in the group, there was an improvement. So what does this mean? It means if you look better and your pressure is under 13, 2/3 of the time, it really was true. You've gotten better. And I'm going to skip over a little bit of this to say it would be better if we had a way of looking at telling who's going to get worse. And the answer to that, Doug brought it over a little bit, it would be so much better than treating everyone aggressively to benefit a minority to be able to identify the ones that were going to get worse. Because we don't have a treatment that's perfectly safe. So it'd be better if we could selectively treat the amount needed for the individual. So that we didn't just have to say, well, your chance of getting worse at this pressure is 60%. Certainly my surgery isn't going to make you worse 60% of the time. I should do something about it. And it turns out, I'm going to skip his study because he already told you about it, that Maria Francesca Cordiero at University of London has been studying apoptosis in retinal cells. Now, this can be done for glaucoma, can also be done for dry macular degeneration, looking at images in the OCTA spectrum. And what she does is annexin receptors that hold annexin, a structural protein in place, come to the surface in eyes that are going into apoptosis. And so the receptors could be on the surface. Normally they are not. And she made annexin-5 and stuck a fluorescent probe on it. Now she injects it into people's veins. It's been shown to be safe. And 2 hours later, you can measure the number of cells that light up. Now, at first, this work just showed in real-time imaging published in Brain in 2017 that it correlated the number of cells you see, but it was very low with this method at first of looking at photographs. The number of dying cells or stress cells correlated with the CCT, with age, and with intraocular pressure and a diagnosis of glaucoma. Very importantly, though, they've now developed a convoluted neural network method of looking at OCTA images that already analyzes them for you and tells you the number of spots in the person that's lighting up. So this is not just seeing dying cells, it's perhaps also seeing stress cells, and they figured out what level was background noise, and it has to be above that. And so they published this in a journal you've never heard of, Expert Review of Molecular Diagnostics. I wish they'd publish one in some, clinical journal. And they've counted these, and then they looked at people whose pressures were in the mid to upper teens on treatment and found that the ones that progressed on OCT in just a course of 2 years were much more than the ones who were stable. And of course, this would be even more than the ones who were normal, but there wasn't a normal control group for it. They're going into, I'm told, a phase 3 trial. So maybe in the future, we won't have to just look at the visual field to stage you. We'll do that, and we'll look at the structure by OCT, but maybe we can also tell how many cells are being stressed right now so that I don't have to wait for you to bump into the wall with your car and say, oh, I'm not on the road anymore, and be able to selectively treat patients who are getting worse. Of course, that has to be proven that it's real, but right now in glaucoma, this is before Hurricane Andrew and there's after, and we don't want our glaucoma patients to do that. Thank you very much.
Thank you, Dr. Pallenberg. Any questions? Sorry. Thank you, Mike.
So you're seeking the ability.
I think you need a mic. It's not.
It's on.
Well, but we're not hearing it.
You're seeking to not treat everybody with admittedly treatments that have downsides and problems. And one way of doing it is Francesca's way.
It may be. Yeah, I hope.
What about going after the people who demonstrate a rapid rate of progression?
Going after them.
More aggressively.
I'm sorry, rapid rate of progression?
Rapid rate of parametric progression.
Yes. Well, I think we do that already anyway. I'm sorry, I'm missing your point.
We sort of do, but we do it with yearly treatment, which means it takes us 5 years to see it. And the average, how long does the average glaucoma patient live? 8, 10 years?
Yeah.
Yeah, it's not good. And more rapid assessment of rate of progression could give you the selective, help you select which
So
patients.
more visual fields, at least at first, once you've settled on your initial treatment.
Yeah.
Yeah. Well, when we had Goldman Field, it was like 6 levels of worsening that I could tell. And now with OCT and Humphrey Fields, I suppose maybe we've got what, 10 or 12 just noticeable differences?
Depends on the average MD at diagnosis. And
Yeah.
in the US, it might easily be that. In Europe, it's the average average MD is more like -10 or -12.
Yeah.
So you got fewer steps. And we are concentrating on the worse eye instead of the better eye, which the better eye is driving quality of life and should drive these risk calculations.
Okay.
Any final questions?
Well, I should probably mention John McSorley. He's my eye doctor and just diagnosed me with normal tension glaucoma. So.
Well done, John.
And Steve Getty is the guy who did the SLT the next day.
Okay, let's move on to our, thank you, Dr. Feinberg. So we have a panel discussion on perimetry here with Mike, Doug, and Murray.
Yeah.
I think Doug can stay there.
Yeah. Or you can come up front if you want, or you can sit right there.
And
you'll be able to see the irritating PowerPoint that we constructed.
So as Mike comes up here, let me explain, hopefully you have enjoyed the program because it really was me bothering, all getting the topics and bothering all the speakers with the idea of trying to run through diagnosis, therapy, and then what's new. And this particular talk, I actually wanted nothing to do with. Years ago, in one of the extraordinary talks I ever attended, we had, like, when the Academy of Optometry was in Orlando, it was 30 years ago. We had Anders Hale as one of the speakers, and for many years the Academy allowed me on a yearly basis to put the glaucoma course together and invite the folks who I wanted. And this particular program, I don't know if Doug still remembers, it was Anders Hale and Dr. Anderson were on the podium, and what happened was it turned out to be a conversation between the two of them talking about perimetry. As compared to somebody being on a podium, it was just going back and forth. So I said, wouldn't it be nice if I had, if I did this with Mike and Doug? And that's how, for this talk that I originally had talked to Mike about. And I said, Mike, I'd like you to do it with Doug. I'll help you put the, the outline and that together, but why don't you do it? And Mike said, I mean, that's a good idea, but I'd rather have you as part of that. So the idea is I'm going to be sitting here, probably saying very little. And I did do the first draft, but then Mike took the PowerPoint and then ran with it. So, so with that, so let me turn over to Mike Patella, who's going to throw up the different.
So Murray came at me with a half a dozen questions. What's up with this? What's up with that? And I sort of stack ranked them because I only thought we would get to 3 or 4 of them at
Yes, we probably have a 2-hour lecture that we have 20 minutes, and the idea is, and the topics are meant to be pertinent. The idea is that this, for the last talk, is we would like to have it conversational, just like that Academy talk of years ago. The one thing I remember of that talk, the reason I don't remember where the Academy meetings were year to year, but I do remember Anders and Mike remembers this. So we invite Andrews Hale, and Andrews lives in a town, Mike, that that must be a couple of 100 years old.
It's 1,000 years old.
Yeah.
It's 1,000 years old. The cathedral is 1,000 years old.
Andrews for his entire time there kept asking, what's wrong with you Americans? How come you're building towns to look old? Don't you realize this is not really old? Remember that? It was just, you know, I mean, and he was right. So, but, you know, yeah, so with that, you know, so we put together a long program, a long topic, but the idea is for, feel free, you know, you have the mics at your desk, interrupt, we welcome everybody's comments.
Okay. So, yeah, you all know that I've worked for, and Murray's consulted for, Carl Zeiss and I've consulted for them for the last 5 years. At the moment, I'm not consulting for anybody, by the way. The topics that Murray put to me were these, and we'll start with the old saw of, is perimetry on its last legs? And will there ever be a time when perimetry is not part of a glaucoma workup? And I can only say never, but not yet and not soon. And we can imagine doing less perimetry and more automated imaging when it's much more foolproof. And OCT just simply has not lived up to its promise, and structural change probably is the key, because the range of normal, which somebody lifted out of, oh, Elizabeth lifted out. Yeah, it explained that all earlier today. That you have to lose about 35% of the average patient has to lose about 35% of their earnethil to fall out of the green zone, and that's even worse than perimetry. So if imaging is going to change the way and the amount of perimetry we do, it's probably got to be based on change, highly specific metrics of change, specific at levels of 99% or higher, for reasons I could bore you with. And it's got to be much more foolproof. We can't be looking at OCTs where 20% of them in typical practice is not a Baskin Palmer, because you have wonderful imaging people here. But in the real world, 20% of the time, they're misleading. That's published, that's known. So
OCT misleading?
Yeah, exactly. In ordinary clinics, in ordinary hands, not in centers like this.
No, I mean, but that's what we're talking about. I mean, listen, I mean, I blame in large part the perimetry, the OCT company for doing a horrible job. They'll sell you a device and then provide very little training, and it's up to you. And on the optometry side, the number of optometrists that are doing OCTs, and they really, I mean, that just happened to my wife. I just mentioned that. I mean, of just, you know, I mean, he's sitting there reading it, and because it's in the red, and I just shook my head and I said, geez, I sent my wife to this person, and this is where we're at. But this is where we're at.
Coming on.
Thank you so much. Go ahead, Barry. I just wanted people to sort of take that in. Do you have any comment, Doug?
Well, I was thinking that the whole problem of judging progression, I look at it this way. If an axon drops out and ganglion cell, do you think you could detect that?
Well, except for Professor Cordero in London.
Right.
No.
Yeah. So that the point that I'm trying to make there is that no, you really can't tell when, but presumably that axon was doing something.
Yeah.
And whatever it was doing disappeared.
So we have a ways to
you
go.
can't detect it because there are, it's just one photoreceptor, or maybe a bunch of them that are related to that ganglion cell, are not doing what they used to do, which might be that they couldn't see a green object, or they couldn't see a flicker
Yes.
or something.
But that also suggests that we need to be able to detect change rather than be limited to normative data. With normative data, we have the variability of humanity to deal with, and that's big.
Well, we can write a book on just the problems of normative data.
Yeah, that's right. And it's especially acute with imaging as compared to function. I have never seen in the years I've been collecting and using normative data for SAP, standard automated perimetry, I have never seen racial differences. And there were some reports of racial differences in FDT. That may be true, but SAP seems to be immune, which is, and Ron Harworth, God bless him, taught monkeys to do perimetry on my machine. And the monkeys were right in the middle of the normal, the human normal, except they were more reproducible because they were better at it. So and in OCT, you're stuck with, we all look different from each other. And Chinese RNFLs are thicker than European RNFLs, and Japanese RNFLs are somewhere in between. So we're stuck with these racial differences in normative data. All that goes away if you can be reliable enough with detecting change from baseline and rates of change.
Yeah, so progression is a different problem from diagnosis. Progression says you're within this range, normal range. Some people have more cones and others, so on. But, and that would be true of function as well as structure.
Yeah.
And the reason there's some difference between function and structure, if we go back to my one axon analogy, if you need a bunch of them, it may be that there's such a crowding of nerve fibers that you don't recognize that, but you can recognize that there's a region that no longer sees.
Yes.
But on the opposite, if it's diffuse, you may see a thinning of the nerve fibers, but you may not appreciate a change in the visual function.
Exactly.
And so that it's not a question that so many pose of which comes first, structural change or functional change.
It's which can you detect first?
It varies from one person to another, and you really depend on being able to do both.
Yep.
And it's different, as already implied, in seeing whether somebody is abnormal or seeing whether somebody is progressing. Those are two different problems.
And what makes visual field testing variable is not probably just a day-to-day thing. They're probably now, we're seeing recovery. We are now seeing that probably one day to the next, the person really is different, and the areas that are sick but not dead are not functioning as well. It makes it a lot harder to tell if somebody's gotten worse.
Yeah.
But I can't, I don't believe a cell can die without losing its function. I mean, that's never made sense to me.
That seems unlikely, doesn't it?
It's just that you can't detect it.
Yeah, of course.
All right.
Just get Mark, you have a question. No, so, just in answering that question, I think we've all had this situation where the patient comes in with large suspicious nerves, pressure may be normal, and, the question is it glaucoma or not? And traditionally, we would get the visual field to prove that it was just physiologic, and now we will, in an ideal world, we get both. We get the OCT and the visual field, but we've all been in a situation where, gosh, the OCT is so normal, and all right, this is just a physiologic cut. But I'm not saying, sure, you wouldn't like to have a visual field, but by now the patient's dilated, and you ask yourself the question, do I really need to bring this patient back? Yes, establish based on that, like another IOP, sure, I'd like to get a visual field, but you're pretty convinced, almost 100% certain. The GCC is normal, the OCT is, RNFL is normal. Do you really need to? And I would say, in that situation, you probably don't need perimetry. Maybe at some point in the future, you regret not having it, but I think that's a very real scenario.
Yeah, I agree. Especially when you have an imaging tech that you trust. Especially if it's you.
The other thing that makes perimetry difficult is it's not just the eye, but it's the person's brain. And whether or not they're alert today or sleepy today, or whether today they decide that even the faintest flicker is something they're going to respond to, or they say, today I'm not only going to respond when I'm absolutely sure I saw that. And that adds a variation that has nothing to do with what's happening in the eye.
Yep. Yep, I agree. Okay.
We all know this. We talk about these.
We are.
Those of us who remember the -1s. So you can miss the blind spot. on a 6-degree grid.
Yes,
No, it's there.
you know it's there and you can miss it. I totally agree. All right.
Hopefully we'll get to those slides, just talking about what's the pattern or
Yeah, that's pretty deep into this lecture. So let me move on to a different one. Video perimetry. We are being peppered by, I don't know, 1.5, 24 startups that think that virtual reality gadgets are perimeters and they want to bring these to market. And is video perimetry capable of replacing conventional projection devices? And I would say not only yes, but hell yes. It's going to happen.
But your caveat is it will happen, but it is not happening today.
It's not happening today for a number of reasons, part of which is that you don't want to hire somebody to build a bridge who's never built a bridge before. And you've got a lot of people trying to build a bridge that never built a bridge before. So that's one. Two, video has a number of technical issues, one of which is the number of light bulbs question. The Goldman perimeter was the perfect perimeter. It had 1 light bulb. The Humphrey perimeter has 3. And the video devices have about 4 million. And it can be solved. And I think I know how to solve those things, but it's not trivial.
I don't know where technology stands at the moment on this. The problem I always had is that, at least for a while, it was not possible to have the background bright enough to be in the photopic range, which is the standard for perimetry, because it's not as variable as when you're in the mesopic range and so on.
We can see video devices at 10,000 ampscales now. They're expensive, but they're possible.
But they're there. Then the next question is, given that background, how much brighter can you make the stimulus? And how does that compare with current?
Well, the starting point for me is, can we duplicate what we do in a projection perimeter in video? And of course, we can't do a full bowl in video yet, but we can do central plus or minus 30 degrees with a 10 candelas per meter square background, standard background, and a similar range, 3,300 candelas per meter square, 10,000 ampscales for max stimulus. It's possible to duplicate that. Nobody's built that yet, but it's the things are on the shelf. The components are on the shelf.
Well, should we start to get used to using size instead of brightness of the stimulus?
We can do that too, although I've been involved in work that suggests that we should just go to size 5 as a standard, except right in the macula and for the fovea, perhaps. And you and I have talked about that study.
Yeah.
So
there's a host of data that suggests that if the Humphrey perimeter today was rebuilt, we built it as a size 5. I mean, just a much better dynamic range.
And better, lower variability.
Yeah.
And I've satisfied myself that you don't really give up sensitivity to early glaucoma. We did that study at 3 sites, Iowa and Toronto and Halifax, 6 years ago. It's been on the shelf ever since.
Has it been in press?
It's not in press. And I have a problem with one of the authors who seized control of that data and just hasn't published it yet. But we presented it at the progression. He has not published that study.
That's what others.
He is. Yeah, but not in early glaucomas. We did early glaucomas. The average MD was like -2. There was nobody with more than 4 dB of MD loss in the sample. And we focused on the central field. And size 5 was at least as good as size 3. Yeah, exactly. And refractively, and it's the key to home testing, for instance. And we showed that size 6 is over the top of the curve and noticeably inferior. And you and I, you did that study, and we.
All of a sudden, so we went to size 6. All of a sudden, end-stage glaucomas had full visual, or advanced glaucomas had full visual field.
Well, it was a size 6 at 10,000 apostomes. It lights up the room 4 times the area. It's big. We actually built 100,000 apostille machine 20 years ago.
So hot, and it gets so hot, and then it's sort of melting the sides that had fans built in. And the patient, when I first got it, the patient was sweating. That bowl is so great.
That's right. So we've been down this road, and I think instead of varying the size, except for foveal thresholds, perhaps, I think we're clear that size 5 is pretty nice because of the refractive stuff and because of reproducibility, and we don't see a downside in early glaucoma.
But one of the issues about, the headset parameters, that Mike has explained to me is that it's not that the light cannot get bright enough, it's that it can't get dim enough. And that's something that, I did not realize, but that's the problem with the technology is not there yet. It can get there. So it's the early small symptomas that it cannot pick up.
Well, you just have to be more precise. The Goldman and the HFA, the tolerances on brightness are pretty big. It's plus or minus 10%. That's half a decibel. But they have separate lighting systems for the background versus the stimulus. And as long as you tolerance both of those plus or minus 10%, the ratios, the contrast ratios work out. The video systems actually have one projection screen that has to do both stimulus and background simultaneously. And once you have to do that, then your tolerances have to be quite a bit tighter. It's a less than 1% thing, and that's not impossible, but it takes care, especially when you have 4 million light bulbs. So, but these are technical issues. This is engineering. It's solvable. It's
going to be expensive.
Well, it could be expensive. I think I know how to do that. Yeah.
But it's why when you see the different headset burners and they say we're comparable, for example, with HFA or anything else, all they show is grayscales. Right. That's a very
one of them is yeah.
It's a very low bar, and that the other studies counting points with early glaucomas and things like that. None of those are out there. So.
Yeah. So the other point is that moving to video is sort of 20% of the battle. If you're starting from zero, trying to build a perimeter, all the other stuff, the data acquisition applications and the data processing applications and the data storing applications are huge tasks, and the software, the hardware is not the big issue. So yes, video, even head-mounted video, is attractive for obvious reasons. It's going to happen, and it.
5 years, 10 years?
No, I think it could be done by a company that gets up and really works hard every morning. 2 years.
But Mike, the testing algorithms are all over the place from these devices, the strategies, It's
yeah, that's right.
They're like, I've worked with 3 of them. And I can't figure out which one is a fast strategy, a full threshold, of this or that. And they're like, and I don't really know what.
Well, that's item B under 4.
Yeah.
Says that all these companies have rushed to market,
right,
thinking that there was an opportunity to take over the perimetry,
right,
field, and they've been rushed.
And it's more about the name of the strategy than whether or not it really works.
They're gonna get there. It's just
Well, they need people. Like I know that Bill Swanson's working in
Well,
this area.
there's the engineering problem, which you already said, which is how do you make enough contrast or whatever that you need? And I don't know whether every other LED could provide the background and then the others.
Well, that's one approach.
That would be an engineering problem.
Yes, just engineering, as we used to say in NASA.
What's that?
As we used to say, I was working on a NASA project 50 years ago, and that's what we used to say. I was only engineering.
But the other half of the thing is whether or not the people who understand the engineering at the same time have somebody on their team that understands psychophysics. So they understand what the contrast needs are in order for something to be visible and how the size interacts with the contrast and so on and so forth. And then there's the testing algorithm, which is really a statistical problem of, if you saw this, will you also see that or not? And so you need a statistician. You need a team that's got a variety of talents in order to create one of these. And I would think that the projection of having one that's really good in 2 years is a little bit optimistic.
And I was thinking if I built it. Yeah, there's a big hill to climb. Even for the knowledgeable academics that have not worked in industry, it's a challenge because they haven't worked in industry. So it could easily take a while, but you know that there are a dozen people that could lead these things, but they would have to learn the industrial stuff along the way to make it work. So my answer is, yeah, it's going to happen. And there's huge improvements in reliability, there are huge reductions in costs that come with this, factors of 2 and 3 and 4 in costs, especially when you take into account the reliability, the price of high reliability. So it'll happen. And
there's certainly a demand from the marketplace.
So,
yeah,
interesting is that,
yep.
I mean, I've been surprised that most of the energy from the companies has been to replace the office perimeter. And none of these companies speak about home perimetry. And that to me, from day one, was the most exciting thing, that you give these, cost-wise, hopefully they'll be cheap enough. And you give them to the patients, and now they start doing the field every week.
Yeah.
And it's just a whole nother way to do it, and yet all they're talking about is put in the office, and I've been surprised.
Well, can you make money doing home testing? I'm out of touch.
Stop.
You know better than the industry.
Yeah, it's the market.
I have with that is that we know that unsupervised patients don't do a reliable visual field test. If they're, even if they're in your office, if the technician is not paying attention to various things, it's not going to turn out well. And home perimetry is yet another problem then, because nobody's supervising it.
I would start with the video clinical device. That's we know how to do that. There's a market for it. And once you have that, then you can move to a home testing device that has less dynamic range and maybe less cost, but which has the same testing strategy as the clinical device, so that within the brightness range of the home device, you can compare results.
I mean, some of these have gaze trackers, and they can have Siri tell you, hey, wake up, look at the spot.
That's right. So
I mean, that.
Yeah. They only have to tell you if it's changed.
That's right.
They don't have to tell you everything.
No, these are people with the diagnosis, and you want to know the rate at which they're getting worse.
If it's, then then you don't have to. As we.
Maybe make the diagnosis.
Just kind of have to know, right?
Yes, that's right. I agree.
Maybe make the diagnosis at home, but do the following. I mean, you do the diagnosis in the office, but do the following.
I think that the ophthalmology is safe in this case. They need. Yeah. So about half the market research that I've done, about half the market is very happy with the central visual field only. And the other half says, no, I want a bulb. Sometimes it's just because they get paid to do that in some countries. And of course, we have no number. Worldwide, it's about half and half. Yeah.
What about the US?
They never.
Time I've ever had a clinician, anybody ever saying that we need a peripheral field, I can't even matter my head.
Yeah, I agree.
I mean, just it's I mean, outside of the occasions where somebody, can need a driving test, or outside if they have some type of disability exam, but for the most part, when they.
Yeah, that's right. That's right. And there's been talk about, do you really need the full dynamic range of the HFA? And it's probably the answer for ophthalmologists is yes. And the reason is for certification of visual impairment, not so much for diagnosis. And because an MD of -22 on a 30-2 test is a legally blind eye in the US, right? Those standards are built in, and that's the way we talk about advanced disease, and especially advanced glaucoma disease. So,
of course, glaucoma is not the only use for perimetry, because you have disability evaluation, driving tests and stuff like that.
Totally agree. Totally agree.
Neurological disease. So
shall we try one more of these? Why, Mike?
Perfect. Great title.
Why the hell did Anders and Mike build a seat faster?
And does it work?
And does it work? Well, we all know that the current recommendations in patients with new diagnosis and newly initiated treatment is to get a bunch of visual fields in the first couple of years, just to sort out the 15% that are galloping progressors. And that recommendation is only frequently enough to catch a 2 dB MD loss per year. That's a person galloping toward blindness, especially if they were diagnosed with an MD of -10. In 12 years, in 6 years, that person is on the doorstep of legal blindness in that eye. So you really don't want to miss people progressing at 2 dB per year. Now the doctors in this room have skills which make them less dependent upon perimetry than the vast majority of clinical eye doctors. They are dependent upon the MD. They're dependent upon the tools we give them, and they were sort of lacking some of the clinical skills to really catch these things when the perimetry doesn't. And so and we also know that most clinics are not doing even enough to catch an MD change of 2 dB per year for 5 years. They're doing yearly testing, and 5 years later, they'll tell you that you're blind. I mean, that's the concern, that's the concern that drove us to try and make a strategy. Yeah.
Can you just wrap up?
I can do that, Barry. I can do that. Yeah. So we built See the Faster by taking cutting every corner we could without losing reproducibility and without obviously losing sensitivity to glaucomatous visual field loss. And we convinced ourselves we were right by running a 5-center international clinical trial. And you've seen that publication. It was in American Journal of Ophthalmology, January 2018. And that study said that the reproducibility was similar to CETA-FAST, that it got different answers from CETA standard, but identical answers to CETA-FASTER, that it was a little more difficult because to go that fast, you really have to make it a more difficult test for the patient, but the patients adapted pretty well, not always the first test, but in general, if you show them what to expect, they'll see it. I won't say anything more except if you read that paper, you'll see that we were pretty careful to do this. And the one caveat is if you have a new patient, new to CETA-FASTER, the parameters should just show the patient what the test is going to be like. And the fact that it's designed to be nearer threshold than the other CETA strategies. If the patient gets that, they're mostly fine. And they certainly learn on the second one.
One thing that should be mentioned in every perimetry meeting is that the patient can pause the test during it by just keeping the button pushed down. This is something Doug Anderson taught me that I didn't know, and it has made the test tolerable for patients. And also, don't go faster and faster because then the machine will go even faster. And that's what you told me.
Yeah.
And making the test tolerable for people that let them know if their eyes feel dry, they can just push the button down, stop it, moisten their eyes by blinking and get ready and let go again. Having the patient in control of the test is probably very important in getting reproducible results.
And that button, that one where they just jammed it down, that is disregarded as an answer. The price is not much to pause the test. Okay, enough.
Yes, it is. We're just waiting to fill up we have a couple of glasses down front here. We can get it from Michael. And with that, so
I'm the designated driver, just a little.
Give me a glass.
Good thing.
Yeah,
Mostly
Ah.
I can see.
then we'll do it.
No, we're good.
Are we toasting Dr. Anderson?
Yes.
No.
So, does everybody have a glass?
So it's always easier to roast Doug Anderson than it is to toast him because it makes him uncomfortable when we recognize how much he's done for us. But Doug, thank you. Thank you for today. And
Does the toasty have a drink too?
Yes.
Or toasty and
yes. Did you ever get any?
yeah, I have some. Yeah, so I got some.
I'm driving, Doug. It's okay.
All right.
We need a little more.
Okay. Long live the Doug.
I might not be able to walk out.
Oh, cheers.
There you go. Cheers. Thank you. Thank you. I read this. This is just another one. You probably have 1,000 of these sitting in your garage. This one says Douglas R. Anderson Award for Excellence. You have an award in that.
Oh, okay. Thank you.
And maybe David will be the second.
So right before Eric just closes out, I wanted to mention that our next educators meeting will be in New York City,
September 9th. So for 1 year, and we welcome your feedback in terms of, in terms of the program. I cannot thank the, Fast Department, the facility, the people here, all the faculty who have given their time